Committee Room 29, sound. 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 Committee Room 29, sound.
Deliberations.
We give it another few minutes?
Yeah.
Okay, good.
Count down from 40 seconds.
I left policing board early, so that's still ongoing. Like,
As I know it, or
I gave up the ghost.
Linda has said that it's still ongoing.
Committee Room 29, sound. Committee Room 29, sound. Committee Room 29, Sound. Committee Room 29, Sound.
So the meeting is open to the public. Committee will be recorded and broadcast throughout Parliament buildings and online. Public gallery, everybody's welcome. Use mobile devices as long as they're in airplane mode. It must be muted, and it's not permitted to take photographs or record any of the meeting. We have no apologies, although Linda is going to be late. She's still at the policing board. And any our members aware of any other apologies? None. Okay.
The others are still at policing board. I had to leave because of another appointment, but a few of the others are still at the board.
Fair enough. We'll get them when they come. So, Chair's business. Just I wanted to comment on two things. One, I suppose the disappointment that the Muckamore Inquiry report announcement yesterday that it's not going to be reporting now until June. I think that's extremely disappointing for two reasons, particularly for the families who are continually being put through the mill in terms of delays. So I mean I think we certainly share their frustration and disappointment with that. And secondly, for the work that we're doing in relation to the Adult Protection Bill, it would have been really useful had we seen the outworkings of the report, because it is important that we know the recommendations. They can fit nicely into the work that we're doing in terms of our own work. So, I mean, we will obviously be doing deliberations later on, but I think it might be worth the committee considering writing to the Minister to ask him if he would consider delaying the consideration stage of the bill till after June, in the hope that the Muckamore Inquiry reports then, and that things can be fitted in if there's any recommendations that come out of that inquiry report or inquiry that impact this, then the amendments and whatever can be made at that stage. So I just wanted to put that in record and to say we can touch on that later on when we're going into our deliberations. Second thing I wanted to just mention is the waiting list announcement yesterday. So I mean, I'm sure we've all seen them and read them, and I mean I think they again just put starkly on record the amount of people across the north who are on waiting lists. And I'm not taking away from the good work that healthcare workers are doing, and that the focus on waiting lists has had in terms of the 200,000 extra in the work to kind of validate the list to ensure that they're succinct and proper. And some of the questions and some of the statistics actually open up many, many more questions that I think we will get into when we have the department on to talk about that. But they just shine a light the fact that our waiting lists here are far too long. They are unacceptably long, and that while some good work has to be done, there absolutely needs to be a focus in the remainder of this financial year, but in financial years moving forward, to address waiting lists. And I mean, we have all expressed concern when we were at the department on to talk about budgets, that 70 million that had been earmarked by the executive for waiting lists wasn't spent this year within waiting lists. So I think that there just needs to be an absolute laser-like focus on waiting lists, particularly red flag waiting lists, because they're totally unacceptable. I mean, none of the trusts are meeting their targets for inpatients, outpatients, etc., etc. So I just wanted to put those two things on the record. Noel, were you wanting them?
Yeah, I was just think it's important to highlight or comment really that what was really concerning, that we saw a release from the Royal College of Surgeons today that said that they need to know where the department needs to be serious and about where the reduction in waiting lists have come from, that they are concerned that it is not actually due to activity, or it could potentially be just administrative changes, and if that's the case, then we need to know, because it was quite clear that the money and the funding that was put in to tackling waiting lists were to go on waiting lists, but also the question is how many were going private. And that's why the waiting lists had reduced. So I think it's like how many people have actually been treated versus how many are on the waiting lists, or and how many have been removed, I think, are two big questions. Just it's worth.
And every time I
highlighting that.
look at these figures or look at figures, they do throw up many more questions.
Yeah.
So, I mean, we're told there was an additional 200,000 outpatients dealt with. We're told that one trust, for example, 40% of people were removed through validation, which, if you kind of extrapolate across the north, is another potentially 100,000 people. And yet, you know, the waiting lists don't really seem to be getting much. Now, obviously, people can go on to the waiting list, but the point you're making and the point made by the Royal College of Surgeons is certainly something I think we need to get on top of it the next time we have in. Just exactly what is going on. I mean, we have asked a number of occasions about the validation and the rationale for people being removed. I think it's very disappointing that we're told they're not collecting those figures, although I think from media today there might be another scenario where they are able to tell some of those figures. So I do think that from the committee's point of view, we need to take a firm action the next time we have the department up in relation to this moving forward. Dan?
Yes, so in relation to your first point about Muckamore, and I made this to the clerk earlier today, it seems to me inconceivable that we would be making law in relation to an adult protection bill without knowing the outcomes and the recommendations of the Muckamore inquiry, because this is the reason we have an adult protection bill in front of us. And rather than have inquiry recommendations and have to legislate further with all of the delay that would mean, I think that we should be writing to the Minister again, asking him to consider delaying the consideration stage until the inquiry reports, and that way we will have a much fuller picture and we will be able to amend, or the department even will be able to amend the bill accordingly. Otherwise, we're stabbing in the dark in many ways, rather than doing work that's profitable and useful and really important. And these are really huge issues that we're considering. So I do agree with that. I think that is really quite an important thing, because you know, as we would have said where I was brought up, it was really the cart before the horse, and we should do it properly informed. The second thing is, again, in relation to waiting lists, we have been having a series of trusts in front of us. Every trust has reported, I think it was the Southern Trust, I'm going to say, reported a 40% drop in waiting lists. I think the Belfast Trust, about a 27% reduction in waiting lists. When we're asked about that, we don't know, and they don't record the reasons why the waiting lists have gone on. So it can be clinical validation. So a clinician has looked at it and said, you don't need this any longer, or you need something alternative. It could be people have gone private, people sadly have passed away. There could be any number of reasons, and we're not recording that data. We have asked of the department, and certainly on our informal session with Professor Taylor, we asked sort of the starting point for each of these, but I don't think we actually have ever gotten those figures. And I think if we're to hold the department to account, the department must supply those. And I suppose the main thing is, the other thing that I wanted us maybe to inquire about, so the biggest reduction in the waiting list, as far as I can see, is in scopes. But that's only one part of a potential journey that patients are on. So is there information and data on, if you've received a colonoscopy, how has that panned out, and what has your treatment been, and what's the completed treatment? How many have reached that completed treatment? Because we can't just take treatments on their own, because one person might require 3-4 interventions. So if we could have, you know, that kind of more rigour to the stats, I think is what we're all asking for.
No, absolutely. It's something that is the number one issue for all of us in this committee, and the number one issue, I'm sure, for the people out there that we represent. In terms of your the point on Muckamore, I mean, I think it absolutely makes sense that we write to the Minister about delaying until June, with the proviso that, you know, we hope the report.
We should complete the legislation in the mandate,
yeah.
but it's not to delay anything,
Yeah.
but it's to make it
better.
Make it better.
Yeah.
Yeah.
Everybody content with that?
Just one issue with that: if the report is further delayed.
Well, that's what I was saying. You know, we hopefully won't come to a point where we might have to move on, given.
Yeah.
No, they've said June, so we hope it is June, and then that would allow. But if
Worth
that's
writing to the
not
chair of the inquiry and let him know this is what we're doing.
Yes.
Yeah, that's a very good
Yes,
point.
I think
We'll do
that's
that
a
as well.
good point. Yeah.
Okay, members, draft minutes then. The draft minutes of the meeting held 26th February are at page 6 of the main pack. Everybody content? No matters arising. Right, so going to item number 5, which is an oral briefing from the department on hospital car parking charges. Can I refer everybody to page 9 of the main pack, and that includes a letter from the Minister detailing the bill which will defer the operational date of the Hospital Car Parking Charges Act. Bill and EM are at page 8 and 11. So can I welcome Mr. Paul Montgomery, Infrastructure Investment Director, Anne-Marie Smith, Infrastructure Investment Director, and Mr. Jeff Thompson, Assistant Director, Facilities and Support, first two within the Department of Health, and Mr. Thompson within the South Eastern Social Care Trust. So you're very welcome. I'm going to hand over to yourself and see if you've, or for you to give us some opening remarks, and then we'll take questions if there are any.
Thank you. Thank you for the opportunity of briefing you today on the Hospital Parking Charges Bill. As you'll be aware, the Health and Social Care Trusts have been working to implement the legislative requirements of the 22 Hospital Parking Charges Act for the past 2 years. The necessary infrastructure was expected to be in place, and the Act was due to become operational from the 12th of May, resulting in charges being abolished for hospital car parking. However, as set out in the previous briefings for the Health Committee by the Finance Director, the Department of Health is facing unprecedented funding challenges in the coming years, and the removal of car parking charges would result in a loss of revenue of approximately £7 million per annum. The simple reality is that if the 22 Act comes into operation as planned, there will be less funding available for the delivery of frontline health and social care services in 26-27 and beyond, when there is already expected to be a significant funding gap. In response, proposals for the further deferral of the ban on charging vehicles for parking in hospital car parks were first circulated to the Executive in October. Following several attempts, the recommendations were agreed by the Executive last Thursday. The next stage is to take the associated hospital parking charges bill through the Assembly. You'll have seen the draft bill. It is a relatively short and simple piece of legislation. Rather than specify a date on which the 22 Act will now come into operation, the bill indicates that this will subsequently be specified in regulations. However, to avoid the risk of indefinite deferral, the bill also includes provision that the specified date should be no later than the 12th of May 2029, equivalent to a delay of 3 years. However, should the financial circumstances allow, the 22 Act could come into operation at an earlier stage, although this looks highly unlikely given the scale of the financial challenge. The bill includes provision that approval of the revised operational date for the Act will be sought by way of a statutory rule, subject to the affirmative resolution procedure in the Assembly. This will provide an opportunity for the Assembly to debate and approve any draft statutory bill rule. The 22 Act is an important piece of legislation for the Assembly, and the Minister is very conscious that he is asking it to make a difficult decision. Unfortunately, given the budgetary challenges facing all departments, there will be more of these to come. In terms of staff permits, during this deferral period, staff permits will remain free of charge. In terms of timing, given the passage of time, it has been confirmed that securing Assembly approval and royal assent of a deferral bill in advance of the 12th of May 2026 is no longer attainable through the normal process, and the bill will now need to progress instead by accelerated passage. This is essential to reduce the risk of charges being abolished for a limited period only and then reintroduced, resulting in reputational damage and potentially significant disruption at hospital sites. In terms of the specific timings for the passage of the bill, the Business Committee has agreed that it can be introduced to the Assembly on Monday the 9th of March, followed by the accelerated passage motion and second stage on the 10th of March. The plan is then for consideration stage at 24th of March, further consideration stage 14th of April, and final stage on the 21st of April. The proposed timetable will leave only a very short period of time to secure royal assent by the 12th of May, with the risk remaining that this will not be achieved and charges may be abolished for a short period of time before being reintroduced. I hope this provides assurance on the need for accelerated passage and that you will support the bill as it makes its way through the Assembly. Happy to take any questions.
Okay. So I think it's important to put kind of on record the rationale for the bill that was supported unanimously through the Assembly in the first instance. Our healthcare workers are some of our lowest paid workers that we have. So hospital car parking charges is an additional tax. We have lots of people travelling from rural areas, patients in very vulnerable periods of their life and taking family members through very vulnerable periods, and again being asked to, essentially what you're asking is, with car parking charges, you're asking patients and workers, and in some cases low paid workers, to subsidise the health service. That's essentially what is a tax on patients and hospital workers. That's what car parking charges are.
No, respectfully, it is not. In terms of the staff, the permits will still be free for them. In terms of
For all staff?
For all staff. Well, it will be free for those staff who are set within the limits of the permits that we have available.
It's important to note it's not all staff.
It's not.
Right.
In terms of the patients, there is a trade-off here. That is simply, we have a pot of money for health and social care services, and we have a choice between that which is provided for care and that which is available to not charge for car parking. And the balance now, because of the financial, I understand at the time the 22 Act was being developed, I understood that the financial position was not quite as dire as it is now, in which case that trade-off allowed for the abolition of car parking charges. However, the pressures we have now and the implications that if we don't do this for the delivery of care mean that the executive has agreed with the recommendations from the minister that the balance is now that we can no longer afford to undertake that, recognising that it will be a pressure. However, the amount that patients and those going to hospital are paying is very small compared to the cost of the care that they will be continuing to receive for free.
So what you're proposing is another delay of 3 years. Why 3 years?
3 years simply to cover the budget period, and that is the period under which we're looking at in terms of our financial colleagues, in terms of that will be the sort of the minimum amount of time that will be required to allow the health and social care sector to become more sustainable and more from a financial perspective. A lot of, I think when David Keenan was here, he spoke about savings required up to 12%. Those sorts of savings will need to be delivered over a number of years. It's not something that can be done in 1 year. It will be a multi-year project, and that's why we've done the 3 years. We don't know what the position will be after in 29-30, so that's why we have sort of done or set it for the 3 years.
In terms of the permits for staff, how much is that costing? The deferral, I can't recall because I think they were previously charged from 2024 or before 24, so I can't recall how much they were. How many?
I think it was about $1 million. It was costing
about £1 million.
Okay,
that cost.
That's across all the trust areas. Yeah. Okay. Thank you, Colin. Sorry.
Philip, sorry, it's Jeff Thompson here, South Eastern Trust. Right. In addition, of course, the Department of Health policy already sets out exemptions and concessions for groups of members of the public and their family as well. And I'd like to work with colleagues in the Department of Health to see how we can review and look at those as well in the intervening period.
Useful. Oh.
Thank you, Chair. Thank you. Yeah, I mean, look, you're here dealing with a mess that's not your making. And I mean, it was totally unedifying that the first bill that was passed here about 2 years ago was the reverse one that was taken as the end of the mandate before, and it just shows the importance of being able to get things right and proper the whole way through. But there were a couple of things in my head reaching back to whenever the passage of the bill was going through, because there was a sense that it was going to be free car parking for all staff. But as that actually then began to work out, it became a permit scheme that was therefore only going to be free car parking for some staff. For by the fact that we're deferring it, was that the way that it was rolling out? It was only some staff that were getting it for free?
I wasn't there at the time.
Colin, it comes down essentially to capacity on site, and I can speak on behalf of the trust that I represent, South Eastern Trust. We have 62% of our space which is dedicated for staff. That leaves just the remainder for members of the public. We can't, and that represents in the region of over 3,000 members of staff. We can't. There's only a finite number of spaces on site, so we also provide free off-site parking for those other members of staff who can't gain access to an on-site permit. So we do the best we can within the finite resource that we have for parking.
And again, that's without blaming yourselves. You can't invent parking spaces if they're not there. But again, it's just as the passage was going through, there was this sense to the wider public that it was going to be free car parking for staff. But yet when it became to the reality, that just wasn't possible because of the physical space. Right. And now we're actually saying that because of other pressures such as income based that we can't continue it. But I was also reminded when I was reflecting that when we were going through the passage of the debate, and I could be misspeaking, so I'm prepared to put a health warning on this at the start of it, but I wasn't sure that whenever we were talking about the cost, the income that was generated, we were always led to believe that the income from car parking was not used to subsidise health, that we were actually told that it was used to subsidise the car parking structures, because I even remember going down a bit of a rabbit hole at a time to say, can you explain to me how it's costing 14 or 15 million pounds per year to maintain what is only a handful of car parking spaces versus what councils spend across the whole of the north? They don't even spend that amount of money maintaining thousands of more spaces. But we were consistently told that there was no income from car parking used to subsidise health. Now what we're hearing is that the income that comes in, this £7 million, if you didn't have that £7 million, then there would be health implications as a result of that. So does that income that comes from car parking, is it used for the delivery of any other element other than car parking?
No, it's actually the opposite. What the income that we're getting from car parking is not sufficient to cover the operational costs. So at the current time, and what we're talking about, if you abolish car parking charges, what you'll be doing is making that the subsidy to the other parts of the health and social care sector. You'll be making that larger. It'll be £7 million more that we'll need to take from the other. So
it would eventually have to come out of the pot that is being used. So it's not that it would be used. The income isn't used, but if you lost the income, then you would have to find the money. The only thing I could do is possibly recommend, and again I'm no expert in this, of going and speaking to road service, because I can guarantee you they do not spend £15 million a year maintaining car parks. I think if we can, they spend significantly less than that on maintaining car parks, and how we have to, in our health service across some handful of hospitals, have to fork out nearly 15 million a year to maintain car parks. But I'm not appraised of all the ins and outs of that, so I'll just leave it as a thought, but I'm happy to be proven wrong, maybe, if I could leave it like that, Chair.
Okay. Danny?
Yep. Thank you, Chair. Colin had asked one of the questions I was going to ask as well. Is it fair to say that a big chunk of that's rates as well?
Yes.
Yeah. What percentage?
It's a significant, it's about 4 to 5 million of the 12 million costs.
Sweet.
No problem. The first question I was going to ask actually is well covered, and I think you'd mentioned it as well, that staff car parking permits will remain free. I know there was significant concerns from staff at the time that some staff would actually lose permits, staff who had permits for many years, and that due to sort of reorganisation of permits and allocation of car parking spaces that they would lose it, particularly I think in the Belfast City Centre hospitals. Can those concerns now be allayed?
Well, we're still proceeding with, because the allocation of permits previously was based on historic first come first serve, and as a result what would happen is that somebody would be maintained, still have their car parking permit because they've been there for 20 years ago, even though they could be parking or they could live much closer, they could have easy alternatives. And that's why the department asked each of the trusts to do a needs-based assessment so that the scarce resource in terms of the permit was allocated to those most in need. Now, there's obviously going to be people who will have previously have received it, and I can understand their anxiety at receiving it, but we have to allocate the resources where they're in most need. And that continues, and we're trying to do that in the fairest, most objective way possible. Don't know whether, Jeff, you can...
Danny, in terms of South Eastern Trust, we've used the needs-based assessment now for a large number of years, probably going back to 2018 on Lagan Valley Hospital site and Ards, and now it's going to the Ulster. That's been equality screened and negotiated with the trade unions. What we're moving towards on the Ulster is a fair and equitable system of allocating, as Paul said, on need. And that's why, and those things take into consideration of business need, personal need, if you've got dependents, carers, or certain Section 75 considerations like blue badge holders as well. So what we want to do is target the finite resource to those who absolutely need to park on site. And unfortunately, with all things that we're facing, it involves difficult decisions, sometimes unpopular, but it is done in the best interest to try and get a fair and equitable system for all our staff, not just those that have held a permit for a long period of time.
I should probably declare an interest as a staff nurse who does bank shifts and does use the car park. Thank you.
So just can I come back on that, Jeff? So you said, I think you said 62% of the car park space was allocated for staff. How many staff percentage-wise are able to avail of that 62%?
Well, I know that there's around about 3,300 staff that avail of that, and we would use for each permits holding space that we have, 2 members of staff have a permit per staff space. I couldn't tell you what the overall proportion of total number of staff. Some staff don't apply, some staff don't need.
Yeah, it would be. I mean, it would be useful because, I mean, what we could potentially be doing here is having a position where we're pushing inequality among staff or inequity among staff, and different hospitals have different structures for giving out free car parking, and plus some might have more available spaces. So I think it would be very useful from the department's point of view if we actually knew right across all the trust areas how many staff were able to avail of permits, and more importantly, how many staff were not able to avail of free parking.
In terms of safeguarding it, the Department of Health has led us to individually as trusts look at it from a sustainability point of view, from business and personal needs. Then it's up to the trust to enter into those negotiations locally with our trade union colleagues to see what's fair and equitable and meets our own needs. And that's why there might be slight divergences in the way that we approach things across the trust, but we are different entities.
And there are different conditions. Overall, I think there are about 7,000 staff permit holders. But in the Northern and Western Trust, there are none, because there's not the need for permit holders, because there's the capacity there. It's simply, if you're in a dense urban area, you have constrained capacity, you don't have the car parking space, so therefore you need to ration it, and that's simply the reality of it.
So the Western Trust don't need permit, all their staff get free parking, and the other trusts, up to 7,000 staff, have permits.
Well, Northern and Western are 0, Southern's 163, and Belfast South Eastern, as Jeff said, about 3,500 each.
Fair enough. Dan?
Yes, thank you, Chair. Could you outline a little bit further how the current are a list of concessions in relation to payment for hospital car parking? And you indicated that you would like to see some of that tweaked, increased. Could you just maybe give us a bit of a view of how you see that developing? Because I do think that is important to us.
Currently, the Department of Health sets their policy, which has, for instance, patients receiving dialysis,
Yes.
chemo, and treatment for cancer. There's also what else is on there? There are people next to kin of people in ICU would be on there as well, and and relatives long stay patients. So what I have noticed over the years will be that these are all by and large quite physical ailments, and I think it's worth exploring things like addictions or CAMs and things like that, where sometimes the actual price of a parking space may act as a barrier to treatment. I think that's a debate that we need to have in terms of policy going ahead.
But no decision's been made by the department in that respect, and no proposal's been received. So we would need to consider that from the departmental perspective in terms of the overall position.
So, I mean, I don't want in this committee for you to throw something out for you then, Paul, to say, but no decision has been made in relation to the department in relation to that. Because I think it's really important. I mean, if someone has addiction issues, that they have equal access to treatment and car parking. So I don't want, and I realise why you're doing it, but in a scenario like this, I don't want us to throw something out and then claw it back immediately almost. That I think is inappropriate. So I would like to see how that conversation progresses, because I do think it is. And I mean, I can't remember off the top of my head when that policy was set down in relation and if it has been revised lately, but at least we should be asking the department to take a look at it, at the very least. I think that's important. That is my view on that particular one. Thank you.
Okay. Oh, Alan, sorry. Alan Robertson.
Okay, let me unmute it, Chair.
Yep, go ahead.
Thanks. Just so that I better understand that, I see in the paper that we got that the Minister had circulated these proposals to the Executive in October 2025. I mean, obviously, this now requires accelerated passage. What was there an issue? Why, given that it was raised in October 2025, why accelerated passage is now required? Given that the department would have had plenty of time to legislate for this.
The department is unable to take forward this and present or introduce the draft legislation until it's been approved by the executive. The executive only approved the draft legislation last week. We presented a number of iterations to the executive and the minister made a number of attempts to secure the approval of the executive, and it was only last week that it was possible.
Kept getting parked.
Can I just ask?
Very smart.
It's we appreciate that it was a very difficult decision that's being asked, because the benefits, as you set out, of the 22 Act and then deferring it is not an easy decision to be making, and we have to respect that.
How much to date has been spent on the traffic management scheme then?
It's a 5 million capital spend to date. Has been
5 million?
Yes.
Okay.
And to be clear, the expenditure on the traffic management scheme will still be used whenever the Act does come into operation, and in the interim it will be of use in monitoring traffic management flows to better use the scarce resources, for example, to identify potentially areas where more car parking spaces could be used or could become available. So in no way will this funding be the 5 million. I appreciate it's a large amount of money, but we are trying to maximise the benefits from that expenditure as much as we possibly can.
Okay, no, that's good. That answers it, that it's money that's not lost. It will, whenever hopefully within the 3-year period when these charges are, or when these charges, or this piece of legislation does come into being, then that it will be put to good use. Thanks, Chair.
Okay, thank you. Thanks very much. Okay, moving on. Item number 6, Firefighters Pension Scheme Amendment Regulations NI. Can I refer members to papers at page 24 of the meeting pack, including the clerk's memo at page 25. and also the SL1 at page 29, proposed SR and EM page 35 and 38, and also correspondence from the department regarding Department of Finance at page 41. So can I remind everybody that SL1 was first brought to the committee on the 12th of February. The committee agreed that it did not consider it necessary to schedule an oral briefing from the department officials for the meeting on the 5th of March. We received no responses to the calls for views on the proposed rules. So do members have any comments? None. Okay, members are can I ask if members are content that the department make the statutory rule? Okay, good stuff. Item number 7, SL1, Human Medicines Regulations 2026. Papers are at page 43 of our main pack. That includes clerk's memo at page 44. The departmental briefing on the SL is at page 48. The SL1 is at page 69, and the proposed SI and explanatory memorandum are on pages 79 and 88. Remind members, SL1 was brought to the committee on the 12th of February. The committee agreed to schedule an oral briefing from departmental officials for the meeting today. So, can I welcome Chris Ireland, Senior Principal Pharmaceutical Officer, Eddie Murphy, Acting Head of Medicines Legislation Unit, and Martin Coleman, Head of Vaccination and Screening Policy. So you're all very welcome. I'm going to hand over to yourselves just to make some brief remarks.
Thank you, Chair, for those introductions and for the opportunity to brief the Health Committee here today on proposals to further amend the Human Medicines Regulations to support the ongoing supply and deployment of vaccinations across the UK. So, Chair, if you're happy, I'll just make a brief statement and then you can maybe ask us a few questions. If
Yep.
Okay. So, as members will know, the UK Human Medicines Regulations 2012, or HMRs as they're better known, govern the arrangements for the licensing, manufacture, wholesale dealing and sale or supply of human medicines for human use. They are made under powers contained within the Medicines and Medical Devices Act 2021, and within this Act, the Department of Health in Northern Ireland is named as an appropriate authority in recognition that the regulation of medicines is a devolved matter to Northern Ireland. Amendments to the HMRs are normally made jointly by the Secretary of State for Health and Social Care in England and the Department of Health in Northern Ireland, as is the case with these regulations. They are subject to the draft affirmative procedure, and Section 47 of the Medicines and Medical Devices Act stipulates that they must be laid before and approved by resolution of the Northern Ireland Assembly. Therefore, an Assembly debate on these regulations will be required. As detailed in the SL1, which was submitted to the committee on the 2nd of February, the policy intent of these planned amendments, alongside the statutory rule itself, was provided along with a company explanatory memorandum in line with the newly introduced 4-week scrutiny period of subordinate legislation by Assembly committees. The SL1 sets out the policy intent of the UK-wide instrument in relation to the amending of existing legislative provisions within the HMRs, which were initially introduced to support COVID-19 and extend influenza vaccination programmes across the UK, namely those provisions set out in Regulations 3A, 19.247A, 2338 and Schedule 17 of the HMRs. This instrument makes amendments to the HMRs to introduce permanent legislative provisions where time-limited provisions made during the COVID-19 pandemic are due to lapse on the 1st of April 2026, and expands the regulations with the HMRs in relation to vaccine supply, distribution and administration to any vaccine against an infectious disease instead of being limited to COVID-19 and influenza. The legislation aims to support development of a vaccination system fit for the future through supporting the safe supply, distribution and administration of a wider range of vaccines both now and into the future. These proposed amendments will increase flexibility in the movement, preparation and labelling of vaccinations in defined circumstances with appropriate safeguards, increase in flexibility in the vaccinator workforce and enablement of community pharmacists to deliver a wider range of vaccinations off-site. The overarching policy objective is to safeguard public health and promote the safety of patients in accordance with Section 2.2 of the Medicines and Medical Devices Act 2021. The provisions in Regulations 3A, 19 and 247 of the HMRs prove vital to the success of the COVID-19 and influenza vaccination programmes during the COVID-19 pandemic and enable the continued safe and effective deployment of vaccines across the UK to help safeguard public health. These legislative provisions are, however, time-limited and have sunset provisions which will cause them to lapse on the 1st of April 2026. Without these proposed amendments to these regulations within the HMRs, COVID-19 and influenza vaccination services will not be able to continue in their current form, and certain HSC vaccination activities will need to cease. Regulation 2338 and 3 and Schedule 17 of the HMRs do not have the same time limitations. However, these legislative proposals suggest ways to further utilise these particular regulations to ensure the vaccine system is as effective as it possibly can be. It is proposed that Regulations 3A, 19 and 233 of the HMRs will be expanded in scope. A new permanent legal mechanism known as a vaccine group direction has been drafted to replace Regulation 247 of the HMRs to include vaccinations against any infectious diseases where these are currently limited to COVID-19 and influenza. This will build on the lessons learned during the COVID-19 pandemic and the successful rollout of the COVID-19 and influenza vaccination programmes. The occupational health vaccinator provisions in Schedule 17 of the HMRs will be expanded in scope to cover any vaccinations supplied in the course of an occupational health scheme. In amending these regulations, we are seeking to maintain important safety measures while also increasing the effectiveness of the system's supply chain and workforce, including health visiting teams and community pharmacists, in order to improve vaccination uptake. Between the 5th of September and the 28th of November 2025, the UK Government hosted a 12-week joint public consultation on amending regulations to support the supply and deployment of vaccines across the UK. The consultation response, published on the 20th of January 2026, detailed how the majority of responses received were supportive of the proposal outlined in the consultation. Many positive comments were received, detailing how the flexibilities provided by the regulations have had a positive impact and helped to increase access to efficiency across the system, while effectively using the workforce to safely deliver COVID-19 and influenza vaccinations. Of the 217 responses received from across the UK, 6 were from Northern Ireland. There was an overall broad level of support expressed in the Northern Ireland responses to the consultation from the Northern Ireland organisations that participated in it, whilst the responses from individuals sharing their professional and personal views and experiences were mixed. Those comments falling into the personal views and experiences were of a more negative nature and unsupportive of vaccines in general. Following the consultation, the Department of Health and Social Care in England laid the proposed instrument in draft on the 29th of January 2026 in UK Parliament, following formal review and scrutiny by their Joint Committee on Statutory Instruments. Their intention is now to debate the statutory instrument in both the House of Commons and the House of Lords before bringing it into force prior to the sunset provisions that I mentioned previously, lapsing on the 1st of April 2026. This is a challenging timescale for both governments, but we're working closely with Department of Health and Social Care colleagues with the aim of laying these regulations in draft in the Northern Ireland Assembly to as close a time frame as possible, pending Health Committee approval of the instrument and its policy intent, of course. In respect of an Assembly debate, it has now been provisionally scheduled for the 24th of March 2026. These regulations are being progressed at pace, given that it is necessary to have these provisions and to support the COVID-19 and flu vaccination programmes in Northern Ireland, which will need to be in place by the 1st of April 2026. The Department of Health has accepted the latest advice of the Joint Committee on Vaccination and Immunisation to offer COVID-19 vaccination in spring 2026 to the following cohorts: all those aged 75 or over, all those living in care homes for older adults, immunosuppressed individuals aged 6 months and over. Failure to meet the deadline could result in eligible individuals being unable to take up their COVID-19 vaccination and will have implications for Northern Ireland and the planned COVID-19 spring vaccination campaign, which is scheduled to begin on the 20th of April 2026 to the end of June 2026, which is around the same time as the spring COVID vaccination programme in the rest of the UK. These regulations have been very successful in expanding where vaccinations can be given, thus ensuring greater access for those who are eligible. And while we acknowledge the challenging timescale in getting these amending regulations debated and made prior to the 1st of April, we would be extremely grateful for the Committee's support and for the progression of these amendments to the floor of the Assembly. Thank you, and I'm happy to take any questions.
Thanks. So there's a lot there to take in, and you're saying this is in relation to protecting public health. So if not implemented, what are the risks to public health?
As Eddie's indicated, there are certain HSC vaccination activities that would need to cease if the amendments were not enacted by the 1st of April. Primarily, Regulation 247A, as currently in the regulations, allows for what's known as a vaccination protocol as authorised by ministers, and that allows for the vaccination parts of the vaccination process to be delivered by non-registered healthcare staff under the supervision of a healthcare professional. If the regulations are not progressed, then that legal mechanism will fall from the 1st of April, and that will have impact on the workforce that is available to deliver vaccination programmes. The other key aspect that will impact is in relation to Regulation 3A, which currently provides for in terms of the activities of thawing and relabelling a vaccine. So currently some vaccine products are supplied at ultra low temperatures within the supply chain. They are thawed and relabelled with a revised expiry date prior to distribution to the final vaccine provider. Again, those provisions currently are able to take place without a manufacturing licence. If the provisions are not enacted by the 1st of April, again, those provisions will fall and that distribution will be impacted. So it will impact on the ability to distribute vaccine to vaccine providers.
Okay, thanks. Can I ask just what steps the department are taking to both promote and maintain public confidence in vaccines?
So it's probably the PHA would probably lead mainly in that, in terms of the monitoring of sort of what is being said in sort of the internet and things like there, and they obviously feed that in, and they would do a lot of social media posts just to try to sort of counteract any sort of negative sort of headlines or any negative stories about vaccinations. In terms of trying to promote vaccines overall, there's various work going on behind the scenes. A lot of the vaccines, not these particular ones, but childhood vaccines are all based on the child health system. It's quite an old, complicated system. So the PHA are working with GP practices just to make sure that they're getting the best out of the child health system in terms of scheduling appointments. And then eventually the child health system will move on to Encompass. So again, that's to make it a more streamlined process and make it the recording of it more accurate and scheduling of appointments more accurate as well, and easier to do for the practice involved. In terms of flu and COVID vaccine, there's various work going on behind the scenes as well, just in terms of behavioural science, just to try to work out what is it that's putting people off from going to get the vaccine, and try to get those sort of things right in terms of trying to encourage people, as personal protection for them, and just to try to encourage them to come forward and take up the offer. Appreciate that COVID-19 in particular is quite a regular vaccine. You get sort of those that are eligible are offered it twice a year. Flu is just once a year. Many other vaccines are just single and one-off. So it is a hard sell to people in terms of just constantly coming back to be revaccinated. But that is the advice from JCVI, so we'll have to make sure that we abide by that advice and make sure the offer's there for those that want to come forward to be vaccinated.
Annie?
Thank you, Chair. Yeah, it's clearly very important legislation. This, we all encourage people to take up a vaccine whenever they're offered. So obviously the ability to deliver those vaccines has to be in place for people to be able to take up that offer. And certainly, the rollout of the COVID vaccination saved many lives here, and we want to encourage that to be able to continue. Just in terms of medicine supply, we've heard some really concerning things recently about possibility of medicine supply being interrupted here in Northern Ireland. Does this legislation affect that at all? Would it be impacted?
No, so in terms of vaccination programmes, certainly the COVID and flu vaccination programmes, and indeed other vaccination programmes, the vaccines are centrally procured. So we procure, the department along with the Public Health Agency procures flu vaccine on behalf of the whole HSC vaccination programme, and similarly the department participates in UK-wide procurement activities for the COVID vaccine and other vaccination programmes. So no, we don't foresee any supply issues at this point.
Okay, thank you very much. Thank you. Okay, members. So just to let you know, we received no responses to the call for views on the proposed rule. So do members have any comments? Are members content that the department make the statutory rule? Yeah. Okay, thank you. Okay, move on now to item number 8, oral briefing from the South Eastern Social Care Trust. So can I refer everybody to papers at page 99 of our pack, and that will, we'll just wait then. Some of them had numbers up at the top. Oh, they have numbers up here, you see. I can't see them. Anyway, not good. So can I just welcome Roisin Coulter, Chief Executive of the Southeastern Trust, Jonathan Patton, Chair of the Southeastern Social Care Trust, Helen Moore, Director of Planning, Performance and Informatics, and Veronica Cleland, Director of Primary Care and Older People Services, all within the Southeastern Social Care Trust. So you're very welcome. Thank you very much for coming. I'm going to hand over to yourselves just to make some opening remarks, and then we'll take questions.
Yes. Thank you very much. Good afternoon, Chair, members of the committee, and thank you for the opportunity to come back to Health Committee. I'm joined by my Chair and Director colleagues here this afternoon, and we are happy to come along to Health Committee to provide you with a balanced overview of the work of the Trust, the progress we're making, outline where our challenges are and the opportunities for stabilising and resetting services across the Trust. First of all, as always, I would like to take this opportunity to publicly thank all of our dedicated staff in health and social care who are working really hard in extremely challenging times to try and deliver the best care that they can. Their commitment to our patients and service users is very much valued by us all, and they deserve our genuine recognition and appreciation for everything that they do. In saying that, I am absolutely appalled that between April to December last year in the South Eastern Trust, there were 1,911 incidents of violence and aggression to our staff. That is completely unacceptable, and I welcome the fact that body-worn cameras are about to be introduced in the emergency department in the Ulster Hospital as a first phase, and this is on the back of the learning from the experience where Antrim Area Hospital have implemented body-worn cameras in a very positive way, so there's been great feedback from that. You will be aware that the Trust provides an extensive range of services spanning acute hospital care, community, out of hours, primary care, mental health, learning disability, children's services, social care and healthcare in prison across all of the 3 prisons in Northern Ireland. But in addition to many local services in the Trust, we provide a number of regional specialist services, including the Day Procedure Centre at Lagan Valley, our regional cataract service at the Down Hospital, community-acquired brain injury rehabilitation services at Thompson House Hospital in Lisburn for all of Northern Ireland, head and neck cancer surgery, oral, maxillofacial and plastics, and our new robotic aquablation urology services, and, as I said, healthcare across the 3 prisons. Similar to all of the population in Northern Ireland, again, Health Committee will be very aware about the significant growth in our older age group. And that is why frailty and providing better services for older people in Northern Ireland absolutely needs to be all of our priority. The most notable change in our Trust is the sharp rise in those aged 65 and over, which is expected to grow by 57%, and those aged over 75 is expected to grow by 72% by 2043, and that is really, really stark. We have the highest proportion of residents aged over 70 across all trusts, with Ards and North Down recording the highest prevalence of dementia in Northern Ireland. People over 75 account for 21% of emergency department attendances and 40% of admissions with a length of stay 5 days or more. There is, as you will all know, a relentless focus on the financial environment in which we are all working across all of our public sector services, and we are trying to do our best to provide the best services we can with the resources that we have available. We do set ambitious savings targets each year to drive out waste, to do our best to improve productivity and efficiency. And this year we are on track to deliver just under £30 million of cash releasing savings, which is almost 3% of our annual budget. But that does take tremendous, relentless focus from all of our teams, and it is everybody trying to do their very, very best to make the best use of the resources that we have got. The reality, though, is that many of our services are demand-led, and they are impacted by both inflation and demographics. So it is increasingly challenging to deliver the same level of services with the same or lower levels of income. Fundamental planned system-wide reform remains the only long-term solution to financial stability across our health and social care system. Underinvestment is particularly marked in community services, and that is having an impact on those most vulnerable in our society, those with learning, mental health and physical disabilities, and looked after children in our care. And this number has risen dramatically from 587 in 2019 to 794 in February this year. In relation to unscheduled care, we are facing a significant demand for services in the emergency department at the Ulster Hospital, and from 23-24 to 24-25, our unscheduled care attendances have increased by 12%. We have the busiest emergency department in the region, with over 162,000 attendances across our 3 sites, and this has continued to increase. In January of this year, the average daily use of additional corridor escalation beds at the Ulster Hospital was 60, and that is on top of a hospital with approximately 550 beds. Every single bed in all of our hospitals open every single day, and 60 escalation beds on top of that. So our teams are working collaboratively, our hospital and our community teams, to do our best to improve flow across our hospital sites. And for example, we have implemented a new passport approach, which is for our frail older population, to allow them, where possible, to be directly admitted by the Northern Ireland Ambulance Service to their local hospital. And we are really pushing to increase that, because that is the best that we would want to do, and have patients admitted. 142 patients in the Down area have the passport, and about 3 years ago that was only 15, and in Lagan Valley 65 patients have a passport, which is giving them direct admission from NIAS straight to their local hospital. So we have a relentless focus on reducing how long a patient remains in our hospitals, and we are continuing to maximise alternatives such as our ambulatory hubs and hospital at home. Over the last 12 months in the Ulster Hospital, our length of stay has reduced by 0.5 of a day. If you add all of that up, that is significant. But it's being very open and honest. The challenges in our emergency department, and at times the very long ambulance turnaround times, they are not unique to the Trust, as we know, and it is a national pressure. However, I absolutely accept that this is not the service we want to provide, nor the service the public or any of our families deserve. And we know how distressing long ambulance waits can be, not just for a patient, but for their families and also for our staff as well. There is no single solution to the complex problem of ambulance turnarounds. There are so many factors that we need to work on continuously to make sure that we deliver an improvement. But we are confident that the answer lies primarily in increasing care available to people in the community and avoiding hospital admission where possible. We are committed and determined to deliver and sustain this improvement, and we have moved from where 51% of ambulances over 2 hours in January to 19% last week. And we are absolutely committed and determined to really making this change and sustain it. In relation to waiting lists, as we know, they are far too long, and we do welcome the non-recurrent funding identified through the elective care framework last March to support our red flag and time critical and long waits, as well as building up elective capacity. We do continue to face the rising demand for cancer services, with a 17% increase in red flag referrals since 2022, which does create pressure and make it difficult for us to meet the ministerial targets. There are, however, signs of improvement, and you may be aware that the South Eastern Trust, we are hosting the single breast assessment waiting list for all of Northern Ireland. And our first breast cancer appointments have reduced from 12 weeks in September to 7 weeks since May 25. Last week we are now down to 6 weeks and 2 days, and there's a lot of work that we're doing in relation to that. And the number of people waiting on the waiting list has gone from 2,500 to 1,498 people waiting today. So we are absolutely determined to work together as a region to make sure that everybody has equal access to that service. We've been able to increase our capacity, and we've managed to deliver almost 80,000 referrals across a range of specialties. There's also been a focus on people waiting more than 3-4 years on waiting lists for access to treatment. And on the 31st of March, the number of people waiting for a first consultant-led appointment, that is now reduced by 61%. And it's been delivered through a variety of ways, not just through administrative validation, but also clinical validation, reviewing the patient's medical charts. We've done additional mega clinics, additional outpatient clinics, and insourcing, working with the independent sector. So all of that is significant, and it's really, really important for people who are waiting a long time. We've also been doing significant work to reduce the waiting times for inpatients and day procedures, and there's been a 77% reduction in day case waits over 4 years as of the 31st of March 25, and a 60% reduction in those requiring an inpatient procedure. Since October 2020, the day procedure unit at Lagan Valley has carried out an additional 22,000 planned surgical procedures, and there is capacity to deliver more for the region at Lagan Valley. The Trust was proud to be the first trust in Northern Ireland to implement Encompass, and also across our healthcare and prison, which interfaces with the justice record. So that is an incredible achievement, given the unprecedented 46% increase in the prison population in Maghaberry since 2021. We are delighted to be the first trust to have mental health staff working with NIAS in the ambulance control room. This is something I think that is going to be really significant for all of Northern Ireland. That has so far helped 1,000 patients to be supported at home instead of in the emergency department. We're having our mental health practitioners sitting aside our NIAS colleagues in the control room, and I also know that NIAS are very keen now to look at having medical practitioners in the control room as well to triage at the point of call. In December, the Trust opened Redwood House Children's Home, and the home is now operational, supporting one family and will support three families by the end of March. We've opened the new urgent care centre at the Ulster Hospital, new pre-operative assessment in paediatrics and endoscopy, and the regional day procedure centres at Lagan Valley and the Down are leading the way in providing vital day surgery. Moving on to talk about our older population. We're continually working with our teams to look at how we can develop more services for our older population and those at the end of their life. There does need to be a reduction in reliance on hospital and more treatment and recovery at home. An older person lying in a hospital bed is not the best place for them unless absolutely necessary. And our aim, and we'll be able to talk about that later, is to provide care at home or as close to home as possible. We've expanded our hospital at home across all of the 3 sectors of the Trust, now providing 40 beds, and patients do feedback that they receive excellent care and experience. Our multidisciplinary teams in primary care is trust-wide and has an excellent community falls service and palliative care hub, and these are essential services to wrap around so that people can receive care in the right place in their community, and I think they would play a key part as we move forward into developing the neighbourhood model. These are really important pillars. So we must prioritise the development of the neighbourhood model going forward, with frail elderly at the heart of it, and we will continue to work with all of our partners, including community and voluntary sector and our councils, to really deliver more care in the community. The patient as our partner will be encouraged to take more responsibility for their individual health and well-being. In Lisburn, a very successful pilot of a dementia behaviours outreach service with 18 care homes has seen a 48% reduction in people with dementia being brought to hospital. And the Trust now seeks, we want to try and expand that service to Ards and North Down and work with our GPs with special interest to support up to 56 care homes in the area. We've embraced digital platforms, Encompass AI and innovative techniques. And we've also now looking to really expand listening to our surgical colleagues who really need more major technological advancements in surgery in Northern Ireland. We've recently welcomed a new surgical robot at the Ulster Hospital which will deliver significant benefits, including reduced complications and faster recovery. In October, we opened a new clinical trials centre at the Ulster Hospital, providing patients across Northern Ireland with access to cutting-edge research trials and innovative improvements. We're working with the region and the Department of Health to implement the transformative Together for Families model, which aims to provide early help for families at the front door, and the intended benefit will be to drive down the number of children that are requiring to be looked after in its totality. Key achievements include the introduction of a revised model to reduce the number of unallocated cases from 515 in June last year to 157 in February, which is a 46% reduction. We've been doing that by providing early intervention services and services in terms of crisis response, with over 247 children are receiving support. One particularly successful service, and I know Health Committee has a lot of interest in relation to children's support services, is in relation to the development of Children's Disability Inreach and our outreach service, providing day short breaks to children, and that is really particularly valued by our families, with one family's feedback recently saying that that is now the preferred option for them to overnight short breaks. So we need to be able to provide both and respond to families in a very flexible way. The Trust does aim to treble this service provision. Mental health services continue to develop new ways to reduce reliance on hospital services and ensure patients receive the most appropriate and timely care in the community. Acute mental health services at the moment are seeing higher ratios of detained patients within the wards and patients with increasing complexities. We are seeing higher referral volumes, and there is sustained caseload pressures right across community mental health, dementia and addiction services. However, building on the success of the Hear and Treat service within the NIAS control room, we hope to expand this model across the week, and we would like to see a See and Treat service where a mental health practitioner will respond alongside a paramedic, reflecting effective approaches that we've learned elsewhere in the UK to provide the right care in the community and really try to avoid hospital attendance unless absolutely necessary. We'll continue to have a focus on making substantial improvements to stabilise our workforce. There's been a considered effort, and we're continuing that effort to reduce reliance on our agency, prioritise our bank staff and expand the bank to include AHP and social care roles. Belfast Trust and South Eastern were working together to share bank resources on a new digital and operational system that would enable bank staff to work flexibly across both trusts. We all know we cannot continue in this constant crisis response in secondary care. The path forward demands that shift to community alongside prevention and the neighbourhood model. And we do have exceptional staff, we have many excellent services, but we do need to work together at system level to really reset health and social care. Every department has a key role to lead and affect this change. Thank you.
Okay, thank you very much. It always kind of puts on record just the vast amount of work carried out by the Trust. So, just like you, I think we should put on record thanks to you and all your staff for the work that you do. And you've outlined a lot of really positive work there. Unfortunately, sometimes in scenarios like this, we want to ask about the stuff that maybe isn't working just as it should. So, just so that everybody is aware, we're going to be really tight in questions, and I'm going to hopefully lead by example here, so everybody will get enough time, but not much more than that. So in terms of your savings, you said there was 30 million worth of savings. I think you said 2%, 3%? 3%. Okay. Can I ask across what areas those savings are made?
Well, every year we always have savings targets, so we're used to trying to make sure that we make the best use of public resources. This year we had more of a significant challenge, I think, than other trusts, and so we did need to really look at a strong governance approach to how we would deliver out those savings. The main areas, I suppose 70% of our resources are spent on salaries and wages. So obviously I think the key thing there for us is to look at how can we stabilise our workforce and make the best use of those resources. So by reducing medical locums, by reducing our reliance on agency, by encouraging staff to come and take a post on the bank, and then by making a number of posts substantive. So that has really helped in terms of reducing our spend on temporary staffing, and that will continue to be a focus. And the other thing that we've been doing is we've looked at our contracting, we've looked at how we can work better with our community and voluntary sector, to join up contracting and delivery of services. We're looking at our admin and clerical roles and how we can drive out the benefits of Encompass. So far, probably this is quite useful in terms of we implemented Encompass first in November 23, so we've delivered out 1.8 million of cash releasing benefits so far, and we have replace 77 posts. So in a way that's a really positive. There's a lot more that Encompass can do, but those would be the main areas so far.
I've asked this, I think, or me or others have asked it of all the other trusts when they're on. So we heard from the independent care providers that there seemed to be some indication that trusts were cutting back on community care as a result, as a method of saving. So I'm just going to put that to you.
Yeah.
I think you can see from the brief in regards to our community care, we had at the end of the last quarter, we had 83 people waiting on packages of care across the South Eastern Trust. So that will demonstrate that no, we're not cutting back on care where it's needed. What we are doing is ensuring that the care is appropriate and it meets the assessed need.
Okay. And I'm going to move on to another subject now. So waiting lists, I think you said, went from 61%. So some of the trusts before us have said that validation has taken away 40%. I'd be interested to know within the South Eastern Trust how many of those that came off the waiting list came off as a result of validation.
Yes, that we have had a series of programme of work which starts obviously with admin validation and moves through a number of steps in the process that have been regionally agreed and arrives at a clinical validation process, some of which would be record review and some of which would require a telephone conversation between the clinician responsible for that specialty and the patient, and in some cases actually also a face-to-face appointment. It's quite a rigorous process, and we have, as you've highlighted there in outpatients, had a 61% reduction overall in the number of people waiting on the time that we are waiting for over 4 years. That has been primarily for long waiting patients, that validation, but we have started at the 4 years plus and have been working right down to 1 year plus waiting. And the validation process, there is scope that if someone has not replied to us and comes back and asks to be reinstated, we can reinstate them. So it's a very clear process that we have adopted.
And you've said regionally agreed.
Yeah.
So I think we in this committee are a bit disappointed and probably confused that we can't go into the specific rationale and reasons of that validation process for why people, I mean, I think it was an obvious question for us in this committee to ask when we first heard it, so I'm just not sure why it's not a pretty obvious question for people who are doing this work to ask, you know, if people are coming off the list for the fact that, you know, they may have went private, they may have...
We actually can provide you, we can send that information through to you in terms of the breakdown, and it's certainly in my experience, listening to, I think, one of the waiting lists in relation to gynaecology, the main reasons are the patient is reporting, and for example hernias is another example, that they no longer require the procedure, or else they've had the procedure elsewhere, potentially in the private sector.
You can provide that information?
Yes, we will be able to provide you that information.
How come other trusts, when we were asked them that, said they couldn't provide it?
Now, we wouldn't be able to provide it for every single specialty, but just where we've done a focused piece of work, then I would be able to give you an example of the percentage, but those are the main reasons.
So this, what you're doing there is going beyond that regionally agreed procedure, is that, am I right?
We've gone down through patient by patient, every single individual.
And in some cases, it would be duplication of referral.
Yeah.
So someone could have been referred into a general surgery and then ended up also coming in under a specialist like colorectal surgery. So it has been quite a rigorous process.
And also they've been referred a number of times, maybe by their GP if they've gone back and they've gone back again, then you will pick up duplicates.
Well, that would be useful if you could provide. I mean, I think it would give us a starting point in terms of, so I mean, good work and waiting lists. In terms of the areas where maybe the reduction isn't just as dramatic, what kind of procedures are we looking at?
Validation is one thing, and then there's also seeing the patients, but it's also seeing the patient in the right place by the right person. And we have been going through a series of reform work to look by specialty about what else we can do. So one of the examples, for example, in gynae is that the team clinically have worked really closely with the GP Federation colleagues, and they have identified some procedures that the GP Federation are trained and capable to provide. And recently over 300 patients in the last few months have been relocated over to the GPs for actual appointments. In addition, we have also been using our physiotherapists to help us with some specific areas of gynaecology. That would be another example. In dermatology, in skins, we have identified that whilst there's a fantastic photo triage service, that there's more scope for about 55% of dermatology referrals do not come with their photograph related to that. That could be if they have multiple lesions, for etc. And we have now successfully worked with the Commissioner, and we're just starting a process with nurse consultants working as part of the whole multidisciplinary and professional group to actually look at what can we do in terms of looking at those dermatology patients that are coming in. And we're hoping when that's up to full scale, 9,000 patients per year will go through the nurse consultant team and not only have to wait for the secondary care consultant in dermatology. So there's been a whole series of reform that has gone on, as well as clearance through the validation process and meeting patients in traditional outpatient appointments. And in addition to that, direct to diagnostic rather than waiting for the patient appointment and then having to go to that.
Last question from me. You outlined, Roisin, that in terms of breast cancer delays, you went from 12 weeks in 2025 down to 7 weeks, and I think you said last week or very recently it was down to 6 weeks and 2 days. Still an unacceptably long delay. I mean, can we get any sense of when we can actually start achieving targets on a sustainable basis?
We are working very, very closely, all the trusts together in relation to this, and this is an absolute priority. So there's a number of things that we are doing. One is we are doing more mega clinics ourselves. I think we did 2 in 1 month there. So taking larger numbers of patients on a given day. I think we did in excess of 50 patients in one day. We've recently partnered with Forth Valley in Scotland, and they have just come over there last week to support Northern Ireland in relation to the breast cancer clinics, and they have delivered 1 clinic so far. We've just got confirmation this morning that there's another one planned for the end of March. So we will see improvement in relation to this.
But of any time when we can actually start making targets sustainably?
Well, I am hoping week on week. So,
Okay.
you know, the week before last was 7 weeks. Now it's 6 weeks and 2 days.
Okay.
So, you know, we're happy to be held to account in relation to this need for this improvement. Now that we have the one waiting list, that is the way forward in terms of equal access, removal of a postcode lottery. So, you know, that is all mainstream now. So what we need to do, and the other thing as well, is not just doing it as we've always delivered, if you like. Forth Valley have a slightly different model where there's different skill mix, there's more role for nursing, etc. in that, and they have an ability maybe to put more patients through the clinics than we are currently doing. So that's another part of bringing them over to say, well, look, you know, how can we do this? How can we put more patients through? So, you know, we will see improvement.
So in terms of, I said that was my last question, it's actually not. So the Minister was given 215 million to tackle waiting lists, and I mean that has been obviously given to trust, but there was 70 million of that was taken from that action and went elsewhere. So in terms of you being able to deal with the waiting lists, you know, if you were given a slice or more of that 70 million, could you do much more? And what could you do?
I think it would be fair to say, you know, if any trust received more investment, we can do more. Yes, we can. We can do more in-house, and we could do more with the independent sector. So we do have capacity, but obviously we recognise when you balance the financial constraints out right across all of the range of services, including community services, learning disability, mental health. So it's probably about balancing the risk. But so, I mean, what we would be doing is absolutely continuing to focus on red flag and time critical services, trying to respond as much as we could to the increase in cancer referrals, and looking at how we can work in greater partnership with general practice. So really making sure the people who are on the waiting lists absolutely need those in secondary care, and that there are really good ideas, I think, from general practice in terms of some of the other areas that they would like to expand into if we can do that.
Orlia?
Thank you, Chair, and thank you very much to Roisin and the team for your presentation at committee today and for the written briefing that we received in our PECs. So I'll try and be quick. So Roisin, just to touch quickly on the mental health stuff, first of all, you have mentioned that you're seeing higher levels of inpatient admissions for more acute mental health problems, which we're probably seeing, I suppose, across the trusts. But in the briefing paper, you have mentioned that in your emergency departments in the past year, well, from January 25 to 26, that you've seen that 28% reduction in mental health admissions in the ED. So just can you outline any reasons for that you sort of assessed why you might be seeing that reduction in ED?
Yes, thank you, Orlia. And this is something, I suppose, that we're keeping an eye on this every single day in relation to trying to provide services for those with mental health challenges. Part of the focus, I think, over the last 3 years with Rachel Gibbs, our Director of Mental Health Services, and the multidisciplinary team, is they have really grasped how we can deliver a shift from hospital to community. So how we're doing that is providing more home treatment, community treatment and crisis response services in the community, so that we can provide something straight to the person but rather than them coming to the ED. And over the last year, yes, we have decreased the number of ED mental health admissions at the Ulster by 26%. So that shows you that we can shift this, but it is about shifting resource as well. So focusing on the community. They also, I think, the fact that we're having pressures is that the vast majority of people within our mental health inpatient wards, they are detained under the Mental Health Act. A large number of people then who are voluntary attending the emergency departments, they are not detained. So we are always having to balance that in terms of access then to a bed will be prioritised for someone maybe in the community who is extremely acutely unwell and needs that bed. So that's why just yesterday I was actually with the team looking at what could we do differently to reduce that even further. Because someone with a mental health crisis waiting 8 or 9 days in the emergency department, we want to get away that is a never situation ideal, and the response to that is to provide more in the community. And it does link in, it links in, as you know, with substance, alcohol, addiction services wrapping around individuals. And, you know, as you know, we have our addiction service in the Downshire and Downpatrick, and that is working extremely well. So it's really about wrapping that up together. And also, I think the partnership with community and voluntary sector have a big role to play, I think, in supporting people with mental health crisis as well. So there's a lot of good work going on.
That's brilliant, Roisin, thank you. And it's great to hear the impact that clearly the work of your mental health team, the impact that that's having. And I'm just wondering, I mean, is this being shared across the trusts? Because obviously each trust has their own sort of pressures when it comes to mental health. And I know that the Belfast Trust, we were meeting with them recently on an intervention, a pilot that they're running, the PATH project, where they're trying to reduce admissions, you know, through triage and people taking them out of the emergency department, triaging them in a separate sort of ward and supporting them, so they might need then to go on into an inpatient unit. But I'm just thinking, you know, if there's learning and if there's good initiatives that your trust has already put into practice that might help other trusts, is there any conversations or shared learning that's ongoing? And secondly, see, in terms of because you mentioned the addictions, has your trust done any work into implementing what we're calling this co-occurrence service, so the dual diagnosis co-occurrence service, where your mental health services are working with addiction services, because that is in the substance use strategy and in the mental health strategy. But when I have asked in the past about how this service is actually being implemented across the trusts, I'm not really getting a sort of affirmative answer.
Yes, okay. No, thank you for that. We absolutely are, you know, probably it's fair to say across all of our services, we are working together as a region. So the 5 trusts, you know, all of our operational directors meet every single week, and you know we are sharing learning, we're sharing challenges, we're sharing opportunities, but we are looking at, you know, more and more how we can deliver services as if we were one. So reducing that variation, trying to consistent practice, getting best practice in place. There is the Regional Mental Health Collaborative, as you know, that is looking at a number of different work streams to make improvements. And again, you know, particularly in our own trust, we did use some of the £2 million on scheduled care investment. We used some of that to support mental health. So we want to develop that 24/7 mental health liaison team, that we use some of that money for our home treatment and community as well, to try and reduce the pressure on secondary care. In relation to your point about the mental health and the addictions, Orly, I'll get that information and I will send it through to you.
Brilliant, thank you. And then maybe my final question then was just because you had touched on it when you were talking about your initiatives around mental health and how you are trying to shift some resource and support into the community, which obviously chimes in with the Minister's whole priority around moving to the neighbourhood model. So when you had touched on that in your briefing, Roisin, you had mentioned around the numbers, the increase in numbers in looked after children, and this really, really, really worries me. Oh God, it just, because obviously we're talking about the most vulnerable within our community, you know, these only kids. And I had done a meeting with a school actually yesterday, and they had said to me around that now it's got to the point that the staff in the school are being contacted and asked to take some of these vulnerable children home because they can't get foster placements for them. There's not always places in residential care for them. And I just thought, how has it got to this stage where teachers are being contacted by social services saying, can you bring this child? Can you take over the care of this child? So I know it's not just your trust again that it's impacting, but there's a lot of these kids don't have social workers even assigned to them. You know, they don't have their own social worker necessarily assigned to them. You had mentioned that there was a 46%, I think I've got this right, reduction in unassigned cases, kids that didn't have assigned social workers. So I'm glad to hear that figure if you have been working to reduce that. But it's bringing it back to the neighbourhood model, and because you had mentioned mental health, learning disability and looked after children, what can we do, or what do you envisage for your trust in terms of this neighbourhood model, how we can try and make an impact and improve the situation for these kids who are really vulnerable and need all the support and help they can get?
Yes. I mean, that's a big question. You could talk for a long time about that. There are so many different parts of that. So in terms of looked after children are almost 800 in the South Eastern Trust area. So we are working very, very hard, to reduce that. In terms of the unallocated cases, what I would say in relation to that piece is that, all of the children who are at risk of child protection have been allocated. So they are all allocated. The other ones are in need of what we would determine family support. I think part of this is whether it's a Northern Ireland issue, whether it's a national issue, but we have seen since COVID, as you're all aware, an increase in young people requiring additional support. And we have also seen a decrease, I suppose, in the culture of the number of people who would like to come forward to foster. And that is a real challenge for us. So I think the response that we are doing in our trust is looking at more wraparound services for families within communities, looking at our early prevention, early intervention, our outreach services. What can we do to keep children as safe and as well as possible? Now, I'm not aware of, I haven't heard of any teachers being asked such a question, so I could appreciate your concern at that. So I don't think I can respond to that. Hopefully it's not. It's not something that we would want to hear too much of. So I think regionally, Northern Ireland, we're looking at together what can we do to really support kinship foster families, so relatives of young people. So, what support do they need to wrap around families to try and keep them close to their home, close to their family where possible. And it really is about that whole piece, as you say, the neighbourhood model, really trying to get upstream. We're working, and this moves out into special educational needs in our special schools, into autism and ADHD services as well. That's what I was saying, it is all linked up together.
Thank you.
Thank you very much, Roisin.
Paul?
Thank you, Chair, and thank you for the presentation, which was at 100 miles an hour like you. You're across so many issues in the Trust, and it was good to get that whistle-stop tour through all of it, sir. Yes, that was the brief version of it, I can be assured. And I also want to recognise and appreciate the good relations that there is between yourself and elected reps. It hasn't always been the case in history, but it has been there. And just to say, Jonathan, it makes life a lot easier in terms of raising issues as an elected rep and having that confidence as well, that it's been dealt with. And I promise that's not the good news before the bad news, but moving into the questions. One of the topics I wanted, it was one that came up recently more here, but it impacts yourselves and us on the ground. And it was that issue because yourself and subsequent or previous chief executives have been so proud of the fact that we've had the one ED in the two level 2 hospitals, and then just suddenly overnight the department told us that they had misdesignated them and turned them into level 1s, which was pushing them down. And it did feel like we lost something in that, even though the services are still there, but it felt with the designation that the sort of springboard from which we would try to build and going further, that we were set back more. Can you explain to us how we got into that scenario of the department misdesignating for years those units? And just I want to put it into the context as well that 372,000 people were about mid-table in terms of the Trust, in terms of population. You've rightly pointed out we've the highest level of those over 70, and we're all getting closer to that. But that increases the number of emergencies. But yet we're the only trust with one emergency department. All the other trusts have 2 emergency departments, but we only have 1. And also that one that we have, if it was a fair wind, I could open the window and throw it here from Belfast and hit it, because it's right on the border of the South Eastern Trust and the Belfast Trust. And I'm sure if you draw a circle around the catchment area of people that gravitate towards it, because if there's somebody who lives at the bottom of the hill here and needs an emergency department, they're going to go 300 metres up the road. They're not going to travel the way down. So I think that sometimes the department is being unfair on the expectation that they have of you in that emergency scenario. And I just wonder, do they make any compensation based on all of that for you? So the designation of the levels and the location of our single emergency department.
Yes, thank you, Colin. And I will talk to the levels, and I will also send you a written response, because we have that. My understanding, and because I think this was about maybe 10 months ago, is that the 5 large acute hospitals, as you're aware, all have a type 1 emergency department, 24/7, full emergency department. And over the last probably 10-15 years, our local services, urgent care centres, our local emergency departments would have been designated at the time as type 2, and that was always the way it was. So again, my understanding, I think it was the Royal College of Emergency Medicine in terms of the designation of the levels of emergency departments. There was a clarification that actually the urgent care centres at Down, Lagan Valley, and there were others in other trusts, but I was just focusing on my own, they would not be called level 2. So it was, I think the local community felt that this was a change as in a downgrading, but it isn't actually any change at all. It's just a clarification which is nationally right across the UK of the types of services and the levels they are. Now, I felt that I was able to explain that I got very few queries about it, but reassure, it doesn't change anything whatsoever. And you talked about having the one emergency department. I actually feel, certainly in terms of my trust, but potentially regionally, I think that's the right model. I think that it is clinically safe, appropriate and sustainable. And it is very difficult to, when you look at the workforce challenges, you look at the financial challenges, the range of services that are required to support a 24/7 emergency department are absolutely vast. So, and we look at the size of Northern Ireland, the population that we have, sometimes people think an emergency department is just a department on its own with a front door and a back door, but it's not. Behind an emergency department, you need access to maternity services, neonatal intensive care services, 24/7 diagnostics. So you need all of that infrastructure behind it. So, how realistic would that be to provide more than one? We have a hospital, and I think it works very, very well, a hospital emergency network model. So we need the three to play their part. They've all got an equal but different part to play. So we have the Ulster Hospital Emergency Department supported by the 2 urgent care centres at Lagan Valley and Down, and they are really, really important. So we have got the ability to take people, admit them directly from NIAS to the urgent care centres, the same to the Ulster. We've got the ability then to manage pressure away from the Ulster at times, if Lagan Valley can take more or Down can take more. So it does work very well, and one of the key things, and I am proud of the model, I really am. I think it's the right model for our population. I think that one of the key things is, particularly in terms of the medical workforce, is that the medical workforce rotate across the three. So there is not the ability of anyone to say, well, I only work at the Ulster, I wouldn't support the Lagan Valley or Down. They will support wherever we need them to support. That is really, really important. And sometimes the smaller centres and the smaller sites actually could be more vulnerable in terms of the rotas and things like that. So that is really, really important. So they all do work right across. In terms of the location of where it is, well, I can't really do anything about that. It is where it is. The geographical location of the South Eastern Trust is somewhere between Cumber, Ballygowan. So that's, if you think about the centre of where we're providing services, as far as Newcastle down to Portaferry, down to Strangford, Ards and North Down, up to Lisburn. So I think whenever you're saying, is there an acknowledgement? There is an acknowledgement of the catchment area and where a population use the emergency department. So 40% of attendances to the Ulster Hospital Emergency Department are from the Belfast Trust of Residents. So there is that acknowledgement. But also, of course, there are a number of people from the South Eastern Trust area that will access services in the Belfast Trust. So, I think that, and probably that happens in all trusts, depending on what services people need. So for me, it's about making sure that our emergency services are absolutely safe, with patient safety being our number one priority, but they're providing clinically appropriate and sustainable services. And I think that the model of our urgent care centres that are working Monday to Friday 8 to 6, supported by minor injuries in the Down at the weekends, that is working really, really well in terms of patient feedback. They are able to phone first. They are able to get access to an appointment the same day or next day. They're able to avoid hospital attendance if need be, but also they are directed to an emergency department if they need to go to it first, rather than go to the urgent care and be sent on. So in the region of 1,300 patients per month are receiving care locally, and there's more to do, of course. I absolutely accept that, and I do think that really, as in Northern Ireland, the priority of frailty and providing better service for older people in Northern Ireland really needs to be an executive priority. We need to get everybody behind this, and there are things that we can do in terms of providing acute frailty units, access to assessment, and maybe you would like to say, Veronica, a little bit about what you've been leading for improving these services.
Absolutely. Within community care, we have a range of services to provide service to people in their own homes, whether it be through district nursing services, who currently provide over 8.3 thousand people on their caseload at the moment, looking after people with the most complex needs, who right through to the end of life. We equally have introduced our hospital at home service. Our hospital at home service provides 40 beds. It's a consultant-led model. People who have used the service are very complimentary of the service. Our length of stay is an average of 7 days. We have sites in North Down and Ards, a site in the Down and a site in Lagan Valley, catering to the local populations. We also, within the Down, we have what we call DAFU, which is an assessment unit for frail elderly people, where they have a one-stop shop basically, where they come in and they have their assessed needs met within that period of time and are able to return home with an appropriate level of care. We have a number of social care packages out supporting people across our community services, with an emphasis on rehabilitation and independence. We are trying to move from a model that is of dependence, trying to enable people to remain as well as they can for as long as they can within their own homes. We work very closely with our GP MDTs, and we have social work teams within that who are helping our population stay healthy in regards to building resilience and managing to reach out to our community and voluntary sector to provide support for them. We have a range of AHPs in our community teams right across from children's services right through to elderly, across acute and every directorate, providing services to enable people to remain in their home and to remain as healthy as they possibly can. Frailty it's a syndrome. There are a number of issues which identify someone as being frail, and it's what we are trying to work proactively with, whether it be through falls, whether it be through polypharmacy and the management of people's medications to ensure that they're optimised for their individual use. But frailty is a range of syndromes, and what we're trying to do is we're trying to keep people at the level, their baseline, keeping them as independent and enabling them for as long as we can. We also, I suppose, should say that as part of that, we are looking to have conversations with individuals, and we're looking because for all of us there comes a point in time where we need to make decisions in regards to long-term care, what our preferences, what our options would be, and through our district nursing services and through our partner organisations, we're having conversations in regards to choice. The last thing we want to do is somebody who's at the end stages of their life being brought to an emergency room or being brought in the back of an ambulance. Yes. So we're trying to be upstream from that and working with our population to identify what their wishes would be at this point in time.
Okay, and I know that certainly it was a stroke of genius for your DAFU of getting Canon Rogan in to do the advertising for it. Went down very well, and I shared that, and people were happy with that. But I suppose, again, perception is everything. And I want to bank what we have as a service is providing a wonderful service, but it's the same thing again. And I suppose that it's a regional thing, but I think that it's maybe just a wee bit more acute in my individual area where I am, which is that the service that you get is fantastic, but it's getting the service. It can be a long wait. I mean, some of the ambulance times for outside the Ulster at like 19 and 20 hours for people waiting in there, and then consequently people waiting in the community for an ambulance is taking even longer. And I think that, yes, I would love just to go right back to the drawing board with the finance and the money and everything and just push the Ulster Hospital 10 or 15 miles down the road so that it is in a more central location, because I do feel that we are losing out because of its location, that it is pulling 40% of people out of East Belfast is not good for the population, as it's our only individual emergency department. And nothing against people from Belfast, but you've got two of your own if you want to go to it, and let us have the one that we have. But just to finish, I think the urgent care centre it is a model that's working. Obviously, I love emergency department. I'd love it 24/7. I'd love it fully staffed and a full hospital behind it. But while the urgent care centre is there, fabulous staff doing a great job, is there any opportunities of expanding that even by an hour a day or 2 hours a day in the short to medium term, on the basis that every individual patient that's there plus family that's with them is one less one that's having to travel over to the fringes of Belfast at the Ulster? Is it something that's not off the table, even if we could have it left there? Is there a possibility?
Well, we could say we can leave it there, but I am extremely honest, and I do believe that the hours are what we can provide. On the basis that it's 8 to 6, and then we've got GP out of hours starting from 6 p.m. to 8 a.m. in the morning, and there is that overlap time. So what I want to try and do is to get as many patients through there as we possibly can. We will keep it under review, but again, we need to be realistic because of the length of time people will be working. It knocks over into other shifts, etc. It's not just a matter of 1 hour, and I think the workforce challenges that we have in Northern Ireland and the financial environment, I do think it'll be quite challenging to expand anything in health and social care. So that is just being realistic. What I want to do is to, continue to look at, and we are doing that. We're not just standing still about taking the same conditions. So our clinical teams are looking at we can do more of. We can take more acute patients there. We can take different types of conditions, absolutely. And I do think that urgent care centres supported by acute frailty units is something where we really can go and link into the service in the community. I really want to get the message across about joining things up to really avoid anyone coming to an emergency department or an acute hospital unless they absolutely need to. That's where we want to get to. Ideally, I would love to be able to deliver that no one should leave a care home unless they've been assessed by somebody, whether it's a GP or NIAS, part of the multidisciplinary team or hospital at home, and that is something that Veronica is looking at, because the experience is quite difficult when someone does, whether their own home or a care home. I'm absolutely determined to really improve the ambulance handovers at the Ulster Hospital again, because the vast majority of people are elderly in the ambulances, and again, these people are our own families and our own relatives. So we will keep a focus on that. And that I can promise you.
Thank you, Chair. Thank you.
Nola?
Thank you. I have 3 questions around 3 topics. Just one is following on from what Colin was asking around there. And it's very easy as a Belfast rep to have access to all those fancy hospitals in the Belfast area. But I think it's really important actually to highlight, do statistics and evidence show that people are missing out? Are people being denied or have a loss of access to services because of where the 24/7 A&E is located at the Ulster Hospital? Are we seeing people suffering the consequences of that? Do you have that evidence or data?
I don't, but what I would say is that everyone across Northern Ireland has access to 24/7 ED, and everybody has the choice of which emergency department they attend, irrespective of which trust they live in. I would think what maybe Colin was referring to was the rurality. So in terms of the access is there and that the facility is open 24/7, but we do absolutely understand that rural areas, public transport, how long it takes someone maybe to actually get to it is longer. So that is a factor, and that is the reason very much why we need to have the urgent care centres in Downpatrick and in Lisburn, to be able to provide that access for the urgent care, so you will only have to come to the emergency department if you need to. And so that's what it is. Those are really, really important parts of the hospital network.
Do you think they benefit? They benefit the system if it wasn't a rural urban issue? Do you think having the kind of detour away from the most serious cases at A&E to actually urgent day centres that actually transforms and benefits an entire health system?
Absolutely, and I think, you know, in terms of the model for urgent emergency care, and then recently in the last 3 years there was the department review of urgent emergency care services, is that, you know, the different tiers of emergency care services, you know, it is a helpful model. So we have got our type 1 emergency department, but it's actually supported by 3 urgent care centres, one in the Down, one in Lagan Valley, and one just last year in the Ulster Hospital. So, you know, enabling that triage of those most acutely ill, whether they're needing resuscitation, major intervention, away from urgent care centres, more people in triage categories 3, 4 and 5. In the Ulster categories, maybe 4 and 5 in the others. Yes, that does, because that means you get quicker access maybe for a higher throughput of patients with lower acute illnesses.
So actually the Belfast hospitals, where it doesn't exist, could learn from the more rural areas and having the day centres. Of course, investment is an issue, but it's something.
Yes, and I think other hospitals have hybrid models as well. So you know, they don't just have the emergency departments; they do also have urgent care pathways.
You see it in an emergency department, you go to
an
emergency department. You know, it's whenever you go to the Royal, the Mater, it is flooded with patients. So it's interesting that, you know, we can learn. It's not always urban does best, but we can actually have learning right across all trusts. My next question is around the breast cancer red flag. You know, we had quite a discussion around waiting lists and, you know, how people have come off waiting lists and been able to provide answers, and you said you provide written answers. But whenever you have a red flag cancer, it's quite often you have to wait, and it is one of the biggest issues that, as an elected representative, that we all get through our constituency office, and it's really difficult to listen to your very distressed constituent who's waiting. And at the minute, a lot of them are around breast cancer referrals. And just following on from what the chair had asked regarding that 2-week target, is it in the current workforce and climate realistic that we would be able to actually meet that and sustain that target? My concern is around we're asking the same people to do more, and at what point can they not do any more?
I think in relation to that, the breast, as you know, is only one of the cancer pathways, and I think it is important just to, you know, to keep that perspective as well. So the target in terms of 14-day for breast care urgent assessment, it's not. The target is not applicable to other cancer specialties. So we absolutely, you know, respect that. I do think it's realistic that we can improve on this. I really do. I couldn't say today whether I feel we can get to 2 weeks or not. I think we can model that out and project. But it's not only a matter, Nuala, of asking people to do more. I think we can't just do that. This is about additional capacity. This is about putting in more clinics, and the trusts doing our own, and also doing the mega clinics, which are on Saturdays, and also then the recent.
Who staffs them, the mega clinics?
Our staff staff them, but at an additional cost, not within their core hours. So we're asking them to do additional.
It's still the same people doing more. So at one point, physically not going to be capable.
And I think as well, the breast being quite complex, and that is a triple assessment. So, you know, you need to have your diagnostics, you need to have your medical and your nursing workforce. And I do really welcome, and I think there will be more in this with the team from Forth Valley in Scotland. So let's see if we can really learn and maybe change.
What would permanently need to do differently and change it for it to permanently? Because my worry and concern is that these will increase, or that these will improve, and then when the foot is taken off the pedal, because we cannot drive our people into the ground, that it goes back up. So what permanently needs to change? Is there a workforce strategy issue, capital investment? What's needed?
Yeah, you can talk about the delivery network.
Yeah, there is a delivery network that has been established with clinicians and operational staff across the whole entire region. Breast as one specialty, as the example being used in this conversation at this point, is actually a one waiting list model. So the long-term solution needs to be a long-term sustainable solution. And that network group are looking at how they're going to do that long-term in a way that, as you said, doesn't put that extra burden on others. In other specialties like dermatology, I referenced the nurse consultant role, and that's about adjusting how we do things differently. And I suppose it's important to remember too that conversion rates for cancer, even though referral demand is up, for red flag referrals is sitting around about 3%, and that has not changed. So for every 100 people, there are 3 very, very difficult situations people find themselves in. But for every one of the 100, the pressure's there. Like, we've been there ourselves, worrying until you're seen. So we do get that.
So I think it is really important and to monitor not just the number of people on the waiting list. So, and I think again that's hopefully it is positive for people in Northern Ireland in relation to the breast piece. You know, in September, this is because we're hosting this for all of Northern Ireland. So 2,418 people were on the waiting list, and today there's 1,482, and we're going to continue to make inroads into that. But we also do monitor, and again that information for yourselves in relation to our regional cancer networks is the number of referrals coming up, how long people are on the waiting lists, and then thirdly, well, what actually is the percentage of people who are diagnosed with a confirmed cancer, and is that changing across the specialties? And that is extremely important, not just about the numbers in terms of accessing the treatment. However, of course, we absolutely understand, you know, how worrying it is when someone is placed on a suspect cancer pathway. Yes, absolutely.
And it should be the case that cancer pathways, when you're red flagged, that it should be a regional model, that, you know, the first available appointment is where you go, whether you're in Belfast and you travel to Fermanagh, it must be the first available appointment for red flag, or vice versa.
And now that we've got this for breast, I think that'll set the way forward for other specialties, definitely.
Okay, and my last question is around respite. Some detail in there regarding Redwood and Lindsay House. We have corresponded before.
Yes.
Consent given from families and everything. Do we anticipate the move between Lindsay House and Redwood would be complete by there's a deadline of, or not a deadline, there's an anticipated March date given, and then there's also the question around the dedicated site for the one individual, and it's gone to SPPG.
Yes.
I understand a business case could go to SPPG, but how has the human impact and human level been passed on? How can we get them to understand that this is actually quite a crucial piece and needs to happen ASAP, because we're talking about very vulnerable families, and there's a knock-on effect.
Yes.
And then there's Belfast families, because Belfast and South Eastern Trust share. Is there anything more detail that you can provide for us on that?
You're actually fully up to speed. That is the current position. You've covered all of that. The progress in relation to it is that, you know, we've worked very well. I know you've communicated with Lynn Priest in relation to that. We've met with families. Our families are being regularly communicated with, you know, on a regular basis, and they are content at the moment of what we're doing for them, particularly in relation to Redwood. And that is why I put that in the briefing, to say, you know, we are supporting one family at the moment, and the feedback, which is, it's so important, isn't it, to share about, you know, are people happy with what we're doing, and that family, as you know, one of the spotlight families, they are happy with the shared care arrangements in place, and they actually feel that you know, that it's very positive, and the young person is thriving. And then by the end of March we will be supporting the further 2 other families. The issue you mentioned in Lindsay House, that is the current position, and there does need to be a bespoke arrangement provided, and sometimes that is complex, and the needs are, the person's needs are the person's needs. So irrespective of the business case or commissioning of the service, we are responsible, and we will need to find a way to provide that.
And how can we get them to speed up? Because in the Belfast Trust, I know that there've been judicial reviews around you know, these delays. How can we get SPPG to actually speed this up?
Yeah, because there are a small number of families who are in this position, but they have such complex needs. What we can do is, you know, to keep having those regular meetings with SPPG, and we are doing that. And I think welcome the focus and the attention from Minister and Health Committee in relation to how important this is. This is an important part in terms of short breaks, day breaks, respite, overnight, all of that needs to be part of this wraparound model. Going forward, it really does. I think and I know Lynn was at Health Committee a number of times, as were the families, is that, the £13 million of investment is extremely welcome in relation to this, but certainly all of the operational leads for these services make it explicitly clear time and time again that there will need to be sustained long-term investment in relation of children's with special needs support. This money is nowhere near enough to deliver this going forward.
Thank you.
Very quickly.
No, that's it. That was my last question.
No, thank you, Danny.
Thank you, Chair. I know we're being timed here at the minute, so we're going to try and bang out a couple of questions. I just have to declare an interest first as a bank South and Eastern Trust. There's lots of really, really good things going on, so thank you very much for your presentation and your report. It's great to see all those things. I just wanted to pick up, I think you started at the start about the violence against staff, and all violence against any healthcare staff is absolutely unacceptable. And the numbers, the committee has been shocked by the numbers that have been reported right across Northern Ireland. We visited Antrim Hospital and seen the rollout of the body-worn cameras there. So very, very glad to hear that there's going to be rollout of the same body-worn cameras to be implemented in the Ulster A&E. Did you say April this year?
We're doing it as we speak. So we're have planning meetings. We're working with the teams to look at how we can go forward. So it'll be happening within the next few weeks.
I'm very glad to hear that, and I'm sure the staff are very keen to see that rolled out. First question, you had mentioned a couple of statistics there about the population growth, forecasted population growth of older people in Northern Ireland. We're all very aware of that, and they are hugely concerning numbers. Have you modelled the need for social care for older people in 2043, as the statistics you mentioned there, compared to the need for social care for older people now? And what is the difference in that need? What is that likely to be? You're being looked at there, Veronica.
Yes. Okay. Have I got? Could I give you a plan on a page? No. What I can tell you is that it remains a continual focus for us. As you know, through the GP MDTs, social work, there's been a social work investment in regards to that and to supporting people, and that was the part that I talked about building resilience, about looking about reablement, about helping people to remain as independent as possible, about redirecting resources out to community and voluntary sector to support people at that point in time. In regards to our resources, our resource. We're not getting any more resources that we're aware of, so we have to manage within our current budget. What we do is we have looked at a number of different initiatives across the communities to support people. So it could be from discharge from hospital, could be the support of the early review team or discharge to assess teams, where you actually follow someone out to their home and you provide a service. You provide that based on, could be occupational therapy, physiotherapy or social work. So it's our focus needs to be about keeping people as well for as long as we actually can moving forward. As I said, we have done a complete piece of quality improvement, working through a quality improvement lens in regards to social care and in regards to home care services. And I've already called out the Q3 where our figures were. That remains a work in progress. There's not just one fix that has helped that. There's been multiple through early review teams, discharge to assess teams, continual review and assessment, support through different means for people in their own home and about redirecting out to community and voluntary sectors. So there is no more resource that we're aware of. So what we have to do is we just have to use our current resources as efficiently as we can to ensure that there's enough to go around.
We can see this significant growth in the older population that is coming down the tracks very, very soon.
Absolutely.
So your spend on social care provision for older people and the rest of the trusts, it is going to be significantly under pressure.
Yeah.
Any idea how much that would increase by, or is it too early? Or
It would be too early to say that. As I say, I don't have a blueprint of costing associated with it, but we can certainly look at that and projections. But every individual is an individual, and everyone's assessment of need is an assessment of need. There's lots of older people living out in communities without any need at all, so it's very, very individual, and it would be difficult to give you an actual figure around that.
And I appreciate there's a lot of work ongoing within that. And one of the things that jumped out of your presentation was the Lisburn Dementia Behaviours Outreach Service, which has resulted in a marked 48% decrease in ambulance conveyances and avoidable admissions. That's a fantastic service by the sounds of things.
It's an absolutely fabulous service, and when you have someone with dementia and behaviours that challenge and difficulties in their place of residence, the last thing you want to do is to take them to somewhere else, take them from their home to somewhere else. It exacerbates the condition. So the Dementia Behavioural Outreach Service is a community. It's like a hospital at home but for people with dementia, and it's part of our neighbourhood. It will be part of our neighbourhood model going forward.
It sounds like it's very neighbourhood model.
Absolutely, yeah. I mean, there's so much going on in the community. Our staff are doing fabulous work.
Brilliant. Obviously, the main issue that we've seen over the last few months has been pressures on ambulance service, pressures in A&E, pressures within wards. Patient flow effectively being choked within our hospitals. Myself and the chair visited Antrim Area Hospital just before Christmas on a Sunday night, where patient flow had stopped. Staff told us, the ambulances were stacked up outside, the unit was full, and the wards were all full to bursting. Now, what we'd seen time and time again is that they're frequently more medically fit or medically optimised, I think is the new term, patients within hospital wards than there are decisions to admit within A&E. So that seems to be the most pressing issue on patient flow. What would make the most difference? What do you not have enough of? Is it care packages, nursing home placements, dementia home placements?
All of the above. All of the above. But I would say if we were to look at any given day, dementia and delirium and suitable categories of care in the sector for people to reside in, that would be where our challenge would be. We do keep a record, and we do report out on a daily basis in regards to people who are medically fit and those who are over 48 hours medically fit, and the reasons for that. So on any given day, and I know we've answered a number of AQs in regards to that, so we do have those stats. But primarily, I would say the biggest challenge in our discharge and making sure their needs are appropriately met would be care home provision in regards to dementia, delirium, additional support in the appropriate categories of care. Now, there is an initiative that has just been rolled out by the provider collaborative, and that's to look to see how we can get the independent sector to engage with us to look to I suppose open more dementia specific beds, and we have looked at a different rate that we will pay them, an entry rate and then an additional support rate, to try to gather some interest in the market in regards to people being able to cater for those with those needs.
Absolutely, and so dementia-specific care home beds is the thing. What is one of the things?
It's one, but I suppose if you look at that, there are two levels of care. One is residential home care, and the other one is nursing care. We are looking internally in regards to our own statutory care provision to see what we can do to look at residential care, to see if we can in some way support that and enable people to transfer out of our acute hospitals.
Because the nursing home placement is all independent sector?
Nursing homes are all independent sectors, yeah.
And is it true that those placements, those beds don't exist at the minute? Is that the?
If you look, and again on a daily basis or twice daily basis, we actually ring around. There is a care home app that's in progress, but we ring around to see what there is, and most days you will have one bed, two beds, and maybe no beds. So it's extremely difficult.
Given what Roisin said earlier on about that projected increase in need, we are going to see that be under further pressure.
Absolutely.
Did I catch right that 19% of your, just to move on to a different subject of ambulance handovers, 19% of ambulance handovers over 2 hours?
Yes.
Is that correct?
Yes.
So that's quite a significant improvement then, is it?
It is, and again, you know, I could honestly talk to you all day about this, and I won't. I'm very aware of the time.
I won't allow.
What I would do is provide you with the assurance that there is a genuine and relentless focus on this from every member of our executive management team, and from our clinical teams as well. And we want to really demonstrate a sustained improvement here. So yes, that's what it was, 56% in January, and last week 19% were ambulances were there over 2 hours. So we need to see what we're doing, 20 things right across the whole pathway to try and deliver that. And we know why. We want to deliver it for the right reasons, you know, for our patient experience, for patient safety, but also to absolutely stand up and share the risk that Northern Ireland Ambulance Service colleagues have in terms of, you know, if an ambulance is outside the emergency department, it's not available to respond to somebody in the community. So we need to share and take ownership of that shared risk, and we do. So the issue is not really, if you like, with the front door, or as in people coming through the emergency department, or with the back door in terms of the discharge pathways that Veronica has said to a major extent. The biggest challenge is the bit in the middle. So the length of stay, how long people are staying in our hospitals, and what we can do differently. And that's by looking at, you know, every other part of the pathway that I've mentioned. So that's what we're doing. There is a hospital and community flow oversight group that is co-chaired by our medical director and director of nursing with our clinical teams, and that, you know, this has got to be, and it is one of the biggest focus that we've got.
One other thing, you've mentioned 40% of patients who are attending your A&E, I think it was, come from the Belfast Trust area. Are you financially reimbursed or anything for that? Is there any sort of agreement between the trusts? Because that's 40% is a huge number.
My understanding is that we work very closely with SPPG, and they commission based on volumes. So they will commission us based on, you know, ED attendances, the number of outpatients, day procedures, and inpatients that we get. So it is based on volumes, irrespective of the trust of residence, because there is a lot of flow across Northern Ireland, as you know, across trust boundaries, and, you know, I think that is only going to increase as we maybe look to more regionalisation and rationalisation of services. So, you know, it's at the moment the commissioning is based on volumes.
I do know just where your trust geographical boundaries are very close to another trust, and certainly the Ulster Hospital is very, very close to that as well. So I'm sure you're going to get. That's great. Well, thank you very much. Thank you, Chair.
So just not quickly into other members' times, but the reduction in ambulance times to 19%. So you said you were doing 20 odd things there. So is that reduction as a result of the 20 odd things you're doing, as a result of the things are doing, or how much of that is just a natural reduction from the busiest time of the year to now?
It's not a natural reduction, Philip. So, you know, we had hoped, and I think our teams would say, you know, by the end of February we would expect to see a decrease. We would expect to see a decrease in demand for unscheduled care coming through emergency departments, but actually this winter we haven't seen that, and that's right across the region. So it is about a concerted focus on sharing the risk with the ambulance service. So we're from the start, from a person's home, really thinking about, you know, Northern Ireland Ambulance Service, do they need to go to an emergency department in the first place? Are there alternatives in terms of referral directly to the hospital at home? Is there admission avoidance in terms of maybe staying at home and being visited by the community team the next morning? You know, really looking at every single part of that. Can they go to the ambulatory hub, and really only conveying people to the hospital if they absolutely need to? And then it is very much about looking at again, hospital at home are doing a great job of actually, and I think this is where we're going to get right back close to people's homes or in their own homes, is that the hospital at home team are pulling right off the NIAS stack directly twice a day. So they are looking at all of the people who are sitting on the list waiting for an ambulance and saying, well, actually, if hospital at home supported that person, they might need the ambulance in the first place. So it is about the relentless focus on every single part of this, and that's where we really want to. We want to really try and improve that. Now, of course, we know it is a national pressure right across. But, you know, if we keep going and looking at the shift to community, that's where the prize is.
Okay, thank you. Dan?
Thank you, and thank you for the presentation. And again, like others, I do want to record my thanks to everyone who works to deliver a service in sometimes very difficult situations. Can I take you back to the waiting lists again? So I hope I've written this down properly. So on the 31st of March 2025, you had 22,108 patients waiting 4 years or more for a first consultant-led appointment. Have I taken that down right?
Yes, that's correct.
You say that now, as of, I don't know, well, we'll say the end of February, there are 8,622 waiting, and that's a reduction of 61%. By my primitive calculations, that's 13,486 patients have come off the waiting list. How many of those have come as the result of waiting list validation in whatever form it is, and how many have been treated?
So actually, as of yesterday, there was 8,422. So another 200 have come off from the previous time when we'd produced those figures in February.
You're upsetting my wonderful
I know.
calculations.
But I just want to play testament to the number of people who are working so hard back in their departments to do this. An element of it is admin validation, and we can send you through those figures. And
No, but all I'm asking for, do you have a figure, a global figure for me that tells me how many came off with waiting list validation? Now, whether that's administrative, clinical, whatever.
Yeah.
How many came off through waiting list validation, and how many were treated?
Yeah. So in terms of validation, there was a number that came off. The number is sitting in and around 26,000 for the totality of the whole trust, including allied health professionals and community. And within the hospital setting itself, it is just about shy of 18,000. But there was a lot of steps in that process and validation that was carried out.
So I'm using the figures that you gave me in your presentation.
Yeah.
So just for ease, just so that we know exactly, you said there were 22,108 patients. This is your...
Sorry, I've gave you the figure for all ins days and outpatients. Sorry, apologies. I've just
so you had 22,108 patients, just so, because we have it here in front of us, if I can even find it now. Anyway, and they've been waiting 4 years or more for a first consultant-led appointment. That was March last year, end of March last year. Now there's only 8,622. That means that 13,486, just working with this figure and not any other figures. Now there are 13,486. How many of those came off the waiting list through validation, and how many came off the waiting list because they were treated?
So I will forward you that information in detail. So I will, but I do know that there has been that process carried out, and the teams back at base are monitoring that on a weekly basis.
We'll send the split.
We'll send it split.
But I'd like to see the split.
You can,
because
absolutely.
I think,
Yes,
I mean,
it's there.
a reduction of 61%, brilliant.
Yeah.
But we need to know how many people are treated, because I think it also says something which I keep harping on and on about. Is the quality of the data that's actually held on waiting lists.
And I suppose just to explain that by one specialty, in gynae itself there was an inpatient chart validation carried out of 397 patients. At that point, 52 were removed. The next stage was actually to look at telephone validation, and they took clinically, that was the clinical validation, they took 284 charts at that point, and they removed 99 patients. And then they did also a face-to-face validation, and that was clinicians face-to-face with a patient. 62 patients come in at that point, and there was 16 removed. So there is a lot of detail behind.
So out of that gynae list then, how many actually were treated? 390, because that's a lot of figures for me on top of my head.
Yeah.
It'd be great if you sent us that, because I think the debate is one, how many people are actually treated? When you talk about a 61% reduction, and I know that's a specific focus on the waiting list of 4 years or more, and I accept entirely that if you're waiting 4 years or more, there are likely things that have happened in between that means you no longer need the service for whatever reason. But I just want to know, if we're talking about a 61%, how many were actually treated?
Absolutely, Diane, and I get that, because we want to show how true the waiting list is, how accurate the waiting list is.
And then I think that the other element that we really need to explore in real detail is the actual data that we keep on waiting lists. I mean, if we've been saying this about our waiting lists for years, and you're telling me that a gynae waiting list that came down to virtually nothing. It's something wrong with the way that we are recording, and I accept entirely also that it's the length of time that people are on the list. And sadly, people have either gone private, they've passed away, they no longer need the service, whatever, or they need a different service. They're not fit for the service that they were actually down on before. So I just think that there's something that we must interrogate about the way we hold the information as well, but also about the number of people we actually treat. So also in terms of the number of people we actually treat, there's been a lot of work done around scopes, etc., and there's a lot of figures given for that. So I'd really like to know the number of people who say, like, have a colonoscopy. How many of those are treated, and how many of them go on to a treatment pathway? And it's a bit like what you said about red flag cancer referrals, only 3% actually. So just so we understand what the information is that we're actually holding and working with, because global reductions like 61% sound amazing until we start to dig into the information.
Yes, and we'll get both of those. I mean, I think in terms of someone, say, the numbers of people having colposcopy that then move on to a treatment pathway, you would have to really look manually into, say, an audit of the last 100 colposcopies that were carried out.
Would Encompass not tell you that fairly quickly?
Encompass, yes, we could do that. We could pull that from Encompass.
I thought this was all the benefits of the whiz of Encompass. I'm kind of looking forward to getting all this information now.
We will send that breakdown, and I do actually agree that is important.
So just so that we know, and that we actually know the real state of the waiting list. How many people then are still on the waiting list for a first consultant-led appointment who are there under 4 years?
I haven't that detail with me, just right off the top of my head.
I think that was just published recently in the quarterly reset
Maybe
statistics.
Just include that in. I understand that, but just include that in it. It's just so that we're sort of starting to understand what's happening in relation to the waiting lists, I think is really important. Another thing, and I've asked this of every trust, so 2% is supposed to be transferred from your secondary care budget into your primary care to accommodate a shift left. What new services do you envisage with that?
Did you talk about that, or told me to? The shift, 2% shift to the neighbourhoods.
What new services? I am concerned, having been round as long as I have, I am concerned. I don't want repackaged. Very nice. I don't want repackaged ideas. I want, what are the new things? What are the things that are going to really make that difference to your budget? Actually, that you can, move it, and to the services that people will get closer to home. Because I agree with you, Veronica. The aim of no elderly person being taken out of a care home because they need fluids or whatever, I think is the way forward. And I don't think that that shouldn't be impossible to achieve. Sure it shouldn't, please.
And I can't tell you that you're not going to get more of the same, but I think there's some wonderful services out there, and what we need to do is we need to expand those services to achieve greater and to be able to reach much more of our population.
If I was to come back to you this time next year, what service would you expand then, first of all?
So one of the examples that we're looking at the moment is our hospital at home service. Yes. Okay, so we have invested in that, and we have our 40 beds. And what we're looking to do is, obviously, we have an evaluation which shows that it is very productive and it's good and it's the right model and it's what people want. What we need to do is we need to expand that service. But how do we do it within our current budget? It's extremely difficult. So what we're doing is we're looking at, we have got support from technology, basically, to help us. So one of the initiatives that we're looking at is with a company, probably can't say who they are, but with a company, and what they are doing is they are building an algorithm which will help us to determine who could be treated, who could discharge earlier from the hospital and free up the hospital services and enable our people to be treated and finish their treatment journey within their own home. Another initiative that we're working with in regards to technology is looking about virtual monitoring and about how we deliver services differently. So
we used to do that, did we not?
There
remember
used to
way
be,
back in the day, in the European Parliament, talking to people about this sort of thing.
But we need,
I think we called it telemonitoring,
virtual warding,
Telecare and
telecare and telehealth, they're still there, and they're still part of what we deliver in regards to health. We've just recently completed a project in regards to cardiovascular, and I heard a gentleman actually speaking in regards to the difference that it made, the introduction of virtual monitoring, and right through to a central point that it made to him in his life, that he wasn't coming back for review appointments and follow-ups, that he was actually in control and had a person to speak to. So what we're hoping, rather than a nurse or a healthcare profession driving maybe down to the very end of the Ards Peninsula to do a set of observations, that we will look to see how this will help us and inform us and reduce what we're doing, but in making sure that client safety and treatment and care is appropriate. So those are a couple of initiatives that we're looking at. We also do need to work closer with our community and voluntary sector, and I did say earlier, we need to support people, we need to support resilience, we need to look to do how do we do things differently, what's available in local communities and local neighbourhoods looking after one another. I think as a society, how we manage this period and the period that we're going into in regards to older people, it will speak volumes, and when we have to do this right for our older population, so we do. So we have lots of great ideas, we have so many committed people who give the extra mile all the time, that work across the services, and it's about how we support them to do it and to do it differently.
And what I would add to that is, just last week I did receive some very positive feedback from SPPG to say that the meeting that you had, Veronica, with them in relation to some of these services, they're actually already doing the neighbourhood model. So we are, bringing new services. It is the right thing to do that shift, absolutely, irrespective of the financial position. And there's a lot of positivity regarding the 17 integrated neighbourhood teams that are going to be implemented in a phased way over 25-26. But what I want to do is make sure there's no duplication, that it is all truly integrated, and that we're making sure that everybody's got a part to play, and appreciating the central and pivotal role that our general practice colleagues will have in relation to the neighbourhood model. That is important. We do need our general practitioners to enable this to work, and I think as well continuing to develop the role of community pharmacies. So all of that will be important in terms of the neighbourhood model, and again, not to forget in any way the importance of the patient voice, and service users and carers need to be really listened to and engaged with in relation to going forward with the neighbourhood model, and that is recognised.
In terms of your social workforce, where are the pressures? I'll tell you why I asked the question. So I asked the question because I do get kind of two levels of pressures that people talk to me. One about the regional service, and the emergency service, and how that is very understaffed, under huge amount of pressure, etc., etc. The second is just on the allocation of social workers to families in need, and I get both of those issues. In relation to not just your trust, but in relation to all of the trusts. And then we've been looking at the Adult Protection Bill, which talks about adult protection social workers. And one of the things I think might happen, and I'm sure that people who are working on the bill won't allow this to happen, I mean, I'm positive sure of it, is that we'll just displace social workers from one thing to the other. And so just very, very quickly, it's one that we haven't touched on here, but I think it is hugely important in reaching out to families in need, and particularly those looked after children. And I must say, I, like Orlia, have had the experience of going into a school where 2 teachers took home children, and those children are still with them.
Very sad.
It is very sad, but how amazing that a teacher, yes, how amazing.
I suppose as you outlined, Diane, it's growing caseloads, growing older people living at home with very, very complex needs. Some people are very lucky and supported by families and close-knit local communities, other people not so much. And obviously they're much more vulnerable. So we do have growing caseloads. We do need to look at, I suppose, we do need to look at how we make sure that there's enough to go round. And as I said, that's about reablement. That's about making sure that people have the right intervention at the right time to help them.
In terms of your workforce, where are the pressures?
The workforce would be growing caseloads.
So it is growing, and do you have a percentage
services.
of vacancies in your social?
I don't have it. Yes, we do have vacancies. We have vacancies across all our services, including our hospital services. So the discharge teams would be hospital-based social work teams. And yes, I can speak that certainly we are working at 65% capacity. And that's not because of vacancies, that's because people are unwell and unfit to come to work. Our community teams equally, we don't have vacancies, there's no vacancy control in regards to frontline staff. Yeah. We do have full quota of staff, but what we do have is we have people who are unwell and are unable to come to work.
So it would be really interesting for the committee, because I think this is going to be an issue going forward. Well, it is an issue now, but one, your experience of the regional emergency social work network. And then, either vacancies or the reasons why you think people are sick and unwell. Is that workforce pressures? What is going on? That.
Yeah, very quickly, because I need to move on to Alan next.
Obviously, I can't speak to every individual case.
But just broad figures, just so we can
get you broad figures. But just to say on your final point, we would absolutely welcome the adult protection bill, and we think that will bring that will bring a very positive note for social work moving forward.
Okay, thank you.
And just in relation, sorry, 2 seconds. The target is 7.66%, and April to December last year, our absence is 8.23%. The two biggest reasons for people being off sick in the health service is stress, whether it's work-related stress or personal stress, and mental health, both in terms of long-term absence and short-term absence. So, you are absolutely right. It is a key part, I think, of this reset. So we have that relentless focus on absence, every single month, and really looking at how we can support people to come to work, to feel safe at work, and to feel valued at work, and to stay at work. So we are really needing to constantly look at that balance, because that is public money resource.
Can I also, sorry.
I need to move on to Alan. Alan.
Okay, yes, thanks, Chair. I'm very pleased, Roisin, to get an opportunity once again to pay tribute and thank your staff across all sections for the level of care that they provide to patients in your trust facilities. Also, it was good to get a trust briefing that contained so much good news. And, there's an awful lot of work goes in to creating good news stats. It just doesn't happen. So well done there. And I know we can poke at waiting list figures and query things in it, but I think the reality is that there's a lot of work, extra work going on in the theatres and in the outpatient clinics, and the reality is that more patients are receiving treatment, and I think that we should rejoice in that fact. But as always said, the greatest asset that the health service has is its staff. And Danny alluded to it earlier, but I didn't catch the period, but you said there's 1,911 incidents of violence to staff. I'm wondering, is it the majority of that happening in action emergency, or does some of it actually happen in ward settings or even in outpatient clinics? And have you a strategy in place, or are you developing a strategy to address this appalling situation? And I know that you've talked about the body-worn cameras, which may help the situation. But my last question basically is do you have a system in place where a staff member who's a victim of violence, it may not be verbal, it might be physical violence, do you have a system in place where they can summon urgent assistance? Thank you.
Yes, thank you, Alan. Thank you for your feedback. Very much appreciated. And in relation to managing violence and aggression, that was from April to December last year. 1,911 members of staff undergoing some kind of incident. Out of that 1,911, 1,200 were physical assault. The highest number is not actually in the emergency department. So there are violence and aggressive incidences right across hospital and in community. The vast majority are actually within the Adults and Children's Directorate. So whether that be mental health, learning disability, there's healthcare in prison, lots and lots of different things. So in terms of what are we doing about it, one is making it extremely clear at every opportunity that this is totally unacceptable for anyone working in health and social care. You should have a safe place to work. The second one is by making sure that we have good governance arrangements in place to support staff. So we have got a regional approach to staff health and wellbeing. We've got our framework for managing violence and aggression. We've implemented a management of violence and aggression oversight group. So there are lots of different things. There are about 12 or 15 responses to whether it's occupational health, whether it's training in terms of managing stress and challenging environments, whether it's individual support if anything happens to someone, making sure that they have that wraparound. There are lots of different things that we have in our toolkit to support, but what we want to do really is to avoid this in the first place. So the body-worn cameras are a positive step, but really we want to send a message out to the public to say, please be courteous and respectful and appreciate that people are doing their very best. I think it's also fair to say that we know that sometimes people are at the point of greatest need whenever they're receiving care or they're waiting for care. So, it's sometimes a symptom of the place that they find themselves in, and we do recognise that. The second one I would want to say is that, I am out and about as much as I possibly can, meeting with staff, listening to managers who are supporting staff who have undergone incidents. I met with staff last week in the Ulster Hospital canteen, and again we've listening to some very significant incidents where actually members of our team coming to harm. Situation within the Ulster Hospital Emergency Department where someone was actually physically assaulted, and the use of a razor blade led them to very significant personal injury, which resulted in a court conviction. So this is the level of risk that people are working in. So it's not just about the body-worn cameras, it is about a culture, and it is very, very important to realise that it does happen right across the piece. And there are reasons and there are drivers, but for us it's about making sure that I know exactly what's happening, where it's happening, and what we need to do to support people. And we do have a number of different toolkits available to support our staff. In the main, people I think do find it difficult to access healthcare, but when they do receive their healthcare, they feel it is of a high quality. So it's really about managing that interface. We do have response from our security teams on our hospital sites, and that's important. And we also, of course, are supported by our PSNI colleagues as well. So it is a whole wraparound, but it is a big focus.
Thank you. Thank you, Chair.
Very much. Just before you go, in terms of, we'll probably write to you in terms of some of the information that you've promised to give us. One question I want to ask, so there's validation, there's people who's treated, and you're looking at people who are on the lists over 4 years. So I take it from one point when you look at it, if you're looking at it 6 months, there will be people added to the list too. So I think it would be really useful if we could get that information, because obviously we want to stop people reaching 4 years. So the more people who are going on, I think that's another piece of information that we would like. So thank you very much. Thank you. That has been very useful. Okay, members, can I just suggest, in terms of that information that we've now asked from the Southeastern Trust, that can we get agreement to write to all the other trusts seeking the exact same information? So the number of people who have come off the waiting list through validation, the number of people who have come off the list through actually being treated and seen, and then also the number of people who are continually being added on to the 4 year level. Happy enough for that?
Absolutely.
Go ahead, Dan.
Through those categories again, could I ask if the number of people that have died on the waiting list?
Well, I mean, we're going to ask again if they will dissect the validation list. We have been told to this point that they can't give us that information because of the regional system they do. Well, no, they said they could do it for some. So I think what we should do is write to all the trusts to see if some trusts can, whatever they can give us. I mean, that's what we want. I mean, I do think that whenever we have the department up, this regional system of validation needs to be updated where it can access that data, because that, I just think that's a very simple first question that you would ask somebody. As I say, last week when you're coming off, email us, they asked you, and so it doesn't seem like it should be that complicated. But anyway, and we have Professor Taylor up again in April, so if we can get this information, it'll allow us to have a better focused session. Moving on, anyway, to item number 9, Urology Services Inquiry. So this is retention and disposable schedule. Can refer members to papers at tab 9 of the pack in relation to containing the retention and disposal schedule. Urology Service Inquiry Retention and Disposal Schedule identifies the disposal arrangements for all records created by the inquiry. So I'm just asking if members are content with that set out. Okay, very right-sided now. Okay. Number 10, written briefing from the Department on the Lifespan Gender Identity Service. So can refer members to papers at papers page 35 of table papers. This briefing was scheduled today, but we've had to reschedule just because of all the business that we're doing. So I'm just wondering if members have any comments.
I think we'll wait till the oral briefing, to be honest.
Okay, thank you. Written briefing, item number 11 from the Mental Health Champion. So it's an update. Can I refer members to papers at page 154 of the main pack. We do have the Mental Health Champion coming in soon too, in person, if I'm correct.
We are due to have an event with the Mental Health Champion in the coming months.
Okay, fair enough.
We're working on that at the minute to look at the neighbourhood model in mental health.
Right, okay.
So that'll be in the coming months.
Okay, fair enough. So do members have any questions, comments on the written briefing? No, okay. So written briefing from the Department on Advanced Care Planning, item number 12. Papers are at page 164. Any commentary on that? None, okay. And again, dental services overview. So that's a written briefing from the Department at page 164. Any commentary? None. Okay, moving on to correspondence. So can I refer members to correspondence in the main pack from page 207, includes an index at page 209. So just there's a few probably. The response from the department at tab 14.2, page 211 regarding cervical smear testing. So they don't tell you why. So I don't know if anybody has any other commentary around that. Okay, another item in correspondence. So the food standard, I should declare an interest. I was at the North's Food and Drink Awards last week, and I was at the table of the Food Standards Agency. So they have written to the committee requesting to present to the committee. So they are under the auspices of the health. They haven't been here in my time. So if members are happy, I think we should invite them for a briefing. Okay. Also can refer members to correspondence from Caleb's Cause at tab 14.14, page 593, regarding a request to present to the committee. Any commentary? So I think we're getting, I know personally I'm getting a lot of requests. So a lot of these, the committee staff should just informal, formal, and we might even increase the number of informal sessions up to 3 in the year, just given the number of requests that we're doing, if people are content. Sense. Okay.
When's the next one planned?
Usually plan them for the
advance of recess.
Yeah, end of June, early July. So that would be the planned next one.
Okay, June. Okay.
We're doing a third one. When would that be then?
Maybe we only do one, do we?
We normally do 2 a year.
Okay.
So one just after New Year, and then one just before the summer recess. If you wanted to look at doing an additional one, we'd probably look the schedule probably September, October time.
I think so. I think just given the
value.
I'll be honest with you, everybody I meet now, wants to come to present to the committee, and everybody has very important issues that I think does members no harm to do the number of meetings.
Can I just say as well, with the clinics that we do, when we do meet with 6 or 7 groups all at once, we've had some really good outcomes from them. You know, there has been progress.
Absolutely.
So I think they're very worth doing.
Okay, so can I refer members also to the correspondence from the Committee for Finance, page 24, table papers, and it's just regarding the Minister's oral statement on the spring budget from the British Chancellor. Any commentary on that? I'm going to make the usual commentary that I always make. I mean, the bill that we're talking about delaying in terms of providing, you know, all of this is a result of us being underfunded. First item, the delay in the car parking. So, I mean, because there's free car parking across the board. So it's all here. All of this stuff is as a result of that. But anyway, that's just me being political. Forward work programme. Can I refer members to draft forward work programme, page 600. Sorry. Is everybody content with the actions suggested in the correspondence? Thank you. Forward work programme. Draft forward work programme, page 600. Number of visits and events are coming up. Members are asked to confirm their availability. So next week we have a visit to Craigavon Area Hospital next Thursday morning in advance of the committee from 10:30 to 12. We're going to get an opportunity for clinicians to demonstrate palliative last aid care template, and department officials also going to be there in attendance. Following that, I'm going to meet, myself and Danny hopefully will meet with the Pharmaceutical Society Chief Executive here at 1 p.m. in Parliament Buildings. Just they want to do a briefing on something. And then the following, Wednesday 6th of May, we have a visit to St Francis Hospice in Dublin. And again, that's focusing on lessons learned and implementing full funding for hospices. And the Permanent Secretary is going to join us as well. So I think that's an important, day out. It's not a day out, it's just an important visit. And then there's going to be an invitation shortly issued to members for informal engagement with the department on the neighbourhood scheme scheduled for 14th of April. So it's just the week after Easter recess, isn't it?
Can I send apologies for the Craigavon visit? I have Police and Board Committee.
I imagine that's the same for all three.
Well, some don't have the same committees. So.
Fair enough.
Sorry, Chair. Just in the forward work, there's Balmoral Show there, and there's no formal meeting on the 14th of May. What's the committee going to be doing at the Balmoral Show?
We are still waiting for discussion with the engagement team. They were waiting to see what other committees were interested in attending and taking part in the Balmoral Show. So I'm hopeful of meeting them in the next week or two to look at what we would plan to do on that week at the Balmoral Show. So I've nothing confirmed yet, but it would certainly be the intention to come back to the committee with a few options.
Okay.
Good enough. Okay, everybody content with the forward work programme I set out?
Yep.
Okay, any other business? None? So can I just seek agreement to move into closed session then to do the deliberations on the bill?
Agreed.
Thank you. Okay, so...
Just wait a second just to get confirmed.
Can I just make a suggestion that we have a 2-minute break? I've just been told that my car's open.
It's open inside if it is.
Committee Room 29. Sound. Committee Room 29. Sound.